That seems really low. There we go. That's better. All righty. Let's go ahead and get started. Let's talk about the important stuff first, the exams. I got them finished. I got the grades posted last night. I will be releasing the exams themselves for review after class today, because again, if I do it during class, you're all looking at that and not paying any attention to me. I was I guess pleased isn't quite the right word, but I guess we'll use it anyway. I was somewhat pleased with the lab exam score. Honestly, it was better than I hoped it would be. The lab exam tends to be very challenging for this one, and I was very impressed with overall how the class did. Again, the average is a little low, 71.24, but again, averages get skewed by some of the extreme scores, and there were a lot of people who did really, really well on this, and the majority of you did adequately on it. There were some people who really struggled in it, and that brings the average down. But overall, I was pleased with how it went. And it was clear that you guys spent a lot of time on the in preparation for the lab exam. And it appears that some of that preparation was at the detriment to the lecture exam. I was somewhat surprised. I know there were a lot of big physiological processes in this one, but I was surprised by the number of people who struggled with the interaction pathways for how lipid-based and amino acid-based hormones affect the cells. Because again, that was one of the things I guaranteed was going to be an essay question. I was surprised that the activation of CD4, CD8, and B cells was something that you guys struggled with. And apparently there was a big confusion between immunity and what we talked about with that whole big flow chart where we talked about immunity, and also how we talked about our body defenses, those lines of defenses. There seemed to be some disparity on that as well. So again, the exams will be released after class today to give you an opportunity to look at them up until tomorrow. So again, tomorrow at around 4:30, I will shut them down. At that point, the only way to see them is to make an appointment and come to my office hours with me. So if you're not able to view that over the next 24 hours, or if you have some questions, please see me about that or email me about it, and we can do that. All right. The good news is, while that lecture exam overall wasn't great, remember your lowest lecture score can be replaced by the final. So if you did struggle with this, there is still ways to improve that. And the most important thing is the overall average. The average in the class is still over 80%, which it definitely should be in a second semester class. Again, you guys should know how to be successful in a class like this, but it's still room for improvement on that as well. All righty, questions on that? All right, let's go talk about our game plan for today then. Today we are going to continue our mystical magical journey through the alimentary canal. As Nabil pointed out, we are still not done with the mouth yet. We spent a fair amount of time in the oral cavity in the last class, and we will continue that today as well, and then continue down. Along the way, I'm going to try to emphasize the histology, because there is a fair amount, even though it's one organ system, there's still a fair amount of histology in this. So we'll try to focus on that as we work our way through.
Last time.
And then you still have a few assignments left, 3 assignments left. Your Unit 24 review is going to be due on Tuesday next week. Physio X Exercise 8 is due next week with all 4 activities. And then on Thursday next week, your Labster is due, all leading up till Tuesday, the 27th, when we will have our lab and lecture exam on this one organ system. All righty. Questions on any of that? All righty then. My stunned silences, which I love so much. All right, excellent. Then let's dive back into the material. We were working our way through the oral cavity. We had talked about the anatomy of the oral cavity. We had talked about the accessory organs that are the salivary glands and the tongue, and that left one set of accessory organs left, and those are the bone-like, but not bones, teeth. Again, we need to know the anatomy of the teeth, the types and their functions, and the difference between our deciduous, or what are commonly referred to the milk or baby teeth, and our permanent teeth. And of course, the dental formula for those permanent teeth as well. when we look at the anatomy, a tooth, as I mentioned, is a bone-like structure, but it is not actually a bone. The majority of the content of it is this material, and I'll go ahead and use green for this, these column-like materials of calcified matrix that are actually more similar to actually cartilage. They're kind of similar to calcified cartilage, and they form these columns of this calcified matrix, and that is known as dentin. So this dentin arranged in these tubules, it forms the bulk of the tooth. The tooth itself is divided into 3 distinct regions. The part when you look into your neighbor's mouth that you see is what we call the crown. The crown is the portion of the tooth that is exposed outside of the gums. And its most prominent feature is that enamel, this substance that is covering the exposed portion of the tooth is our enamel. It is comprised of calcium salts and hydroxyapatite crystals. Remember, hydroxyapatite crystals were that strongest substance produced by the body. It's what we also use to make the bones. However, the difference between the bones and the crown and this enamel is that our bones, remember, have a large amount of collagen fibers in them, whereas our crown does not. That collagen fiber in the bone makes it flexible, gives it some give, allows it to resist those shearing and those twisting forces, but still be hard. The enamel is incredibly hard, but has no collagen, so has no give. So if over the summer you were trying to drown your sorrows in a big bowl of New England clam chowder because the mighty Tom Brady left to go to Tampa Bay, right? And you bit on that clamshell, then as a result of that, there's no give, and you could end up cracking or breaking the enamel as a result of that. Because while it is incredibly hard, it is brittle because it has no give. The second region of the tooth is, let me clear this off, the root. I want to talk next about the root. The root is the part that is embedded within the alveoli, or the pocket of the tooth, pardon me, pocket of the bone, either the 2 maxillary bones for the upper jaw or the mandible for the lower jaw. There is an alveolus, or a pocket, within that tooth, pardon me, within that bone for the tooth. And there is a joint that holds this together. Even though the tooth is not a bone, we do consider this connection between the tooth and the socket to be a joint, right? And someone remind me, what is the structural classification of this joint between the jaw and the tooth? Well, that's its functional classification, so that works. What does that mean to be a synarthrosis? Right, it's a non-moving joint, right? So that's its function, how much movement that joint allows. This one doesn't allow any. We shouldn't let the teeth wiggle around inside of our mouth. But remember, the functional classification involves what kind of connective tissue holds the 2 bones together. And in this case, what is the type of connective tissue that holds these 2 bones together? Well, dentin, remember, is the bone-like substance, the cartilage-like substance of the tooth, right? Remember, like the pubic symphysis is a cartilaginous joint where it's cartilage holding things together. There you go. There's a ligament that holds it together. So if there is a fibrous ligament that holds the 2 bones together, then what would the structural classification of this joint be? I know you guys learned this stuff in 430. Nope. If it's a fibrous ligament that holds it together, what is the structural classification of the joint? You all took 430. You all learned. Well, you're correct. We'll get to the gymphosis, but we haven't gotten to the specific type yet. Right? That is definitely the funnest thing to say. Specific type of joint is indeed a gymphosis. But what is the structural classification of a joint where you have a fibrous connective tissue holding it together? Fibrous, there you go, excellent. Perfect, spectacular. As I'm sure you all remember from 430, and if you don't, shame on you. Again, we don't randomly just throw crap at you in 430. You learn stuff you need to use. And here we go. Structural classification of this joint is a fibrous joint. Functional classification is a synarthrosis. And the specific type of joint is a gymphosis. You absolutely positively needed to know that in 430. And since I'm talking about it here, do you think those are all lab type questions I could ask in this class as well? Absolutely. Excellent. Notice what I've drawn here in purple is their representation of that particular ligament that holds the tooth in place with the bony socket. It is what is known as the periodontal ligament. So that is that ligament there. However, I do want you to notice one other thing about the tooth. If we were to yank this tooth out of the socket and look at it, you would not see the dentin. Because in this region, if you look, there is a thin layer of material that lines the portion of the tooth and connects to the ligament, anchored in place. Anybody know what that material might be known as? Well, when all else fails, you can cheat and look at the model, look at the illustration. There you go, exactly, cementum. Cementum, absolutely. So there is enamel over the crown of the tooth, and there is cementum over the root of the tooth. So the outer surface of the tooth is covered by material in those two regions. Notice that cementum does go most of the way up to where the enamel starts. But the problem with that is that brings us to the neck. Cementum is again, it is kind of like a calcified matrix. It is a bone-like material, but not quite bone, kind of like the enamel. But it is a hard calcified substance. All right. So notice the outer surface of the tooth is protected by enamel. The crown is protected by enamel. The root is protected by being embedded within the bone. And that brings us to the neck. The neck isn't protected by bone. The neck isn't protected by enamel. What's the neck protected by?
Gums?
Yeah, the gums, the gingiva. Absolutely. And are your gums very protective?
Not really.
No, not really. Exactly. It's one of the reasons why it's so important to take care of your gums. Make sure you floss, but not vigorously every day so you're not damaging and inflaming them, because we want to maintain the integrity of those gums. If your gums start to recede, then as they recede, basically your tooth is exposed in a weakened part, and a lot of cavities can actually form on these lateral surfaces where the neck of the cavity, where the neck of the tooth is located. So we have these three regions, the crown, the root, and the neck. And again, those different substances that cover them. Now notice the tooth is hollow on the inside. There is a big, huge cavity on the inside. And guess what that cavity is called? Pulp cavity, excellent. It is the pulp cavity. Guess what the pulp cavity contains? Pulp, excellent. Pulp is an areolar connective tissue with nerves and blood vessels inside of it. Right. Notice the root canal, as was mentioned, is the portion. Let's do this. The root canal is the narrow neck-like portion of the opening that passes through the root of the tooth. And then notice there is a small hole, a small opening at the apex of the tooth known as the apical foramen. So we see that apical foramen, which is where the blood vessels and the nerves come into it. This is the part where if you have a cavity that is causing irritation or problems with the nerves, then what the doctor does is takes his drill, drills down in, basically destroying the pulp in this region and fills it with a whole bunch of epoxy, essentially killing the tooth, right? Removing the blood vessels, removing the nerves so that it doesn't cause pain anymore, and then puts that enamel on top so that it maintains the color and stays closed to protect the jaw. All right. Questions on the, we did that. Here's another nice picture that shows, again, all of these regions that we talked about on a different shaped tooth. The previous one is more of an incisor shape. This is more of a molar shape, but we see it all has the same basic anatomy to it. And that brings us to the next part, the classifications of our teeth. We have our incisors. They're the ones that are most anterior, most medial. They have a chisel shape. So obviously, if you're removing the blood vessels and the nerves, then the dentin tissue dies, but it is covered by that hard enamel. I mean, in the long term, 60 years, is it possible that there could be deterioration of the tissue as a result of that? Yeah, maybe, potentially. But for the short term, I mean, I'm not encouraging everybody to go out and get root canals and kill all your teeth so you never feel any pain in your mouth or in your teeth. But I think in the short term, there isn't any major implications to it. The only thing that I would say is sometimes when the removal of the nerves and the blood vessels, when the tissue dies, you can get a darkening of the tooth. So sometimes that will happen when the tooth dies. The color can darken as a result of that. But again, they have ways to fix that too. And it's certainly better than getting an infection that can travel back up the nerves and into the maxillary sinus or something along those lines as well. So if it's a choice between getting a root canal and having an infected tooth, I suggest you take the root canal. All right, so we can tell a lot about an organism by the shape of its teeth, right? Wolves have big, huge, sharp, pointy teeth. Sheep have big, broad, flat teeth, right? Because of course the sheep eat grasses and things along those lines, and the wolf eats meat. We are omnivores, which of course means that you eat anything you can get through a drive-through. And so not surprisingly, we have a variety of shapes to our teeth. Like I said, the medial and anterior teeth are the incisors, chisel-shaped teeth that are good for pinching and grasping. We have our own canines, fat fang-like teeth for grabbing and tearing. They're lateral to the incisors. And then posterior to those, we have our premolars, also known as bicuspids, and our molars, which have those big round crowns for grinding and smashing. So 3 main types of teeth for those specific functions for our omnivore lifestyle. Here we see the organization of them on one side, both upper and lower jaw. And as you can see, there is a specific number in an adult, and that's really the key here. We're talking about adult teeth here. There are on each quarter of the mouth, so top and bottom, left or right, there are 2 incisors. Oops, I show there's a Q there. 1 canine, 2 bicuspids or premolars, and then 3 molars. So that dental formula of 2, 1, 2, 3 is the dental formula showing the number of teeth you have in one quadrant as an adult. But we don't necessarily start with adult teeth. We actually have 2 sets of teeth. The first are what are called our primary, our deciduous milk teeth, or what sometimes are commonly referred to as our baby teeth. You get a total of 20 of these, and I like the picture from your textbook because it gives a nice idea of how they come in. Usually these teeth fully come in by the first 2 years of life. Notice starting first with the incisors as early as 6 to 8 months, then the lateral incisors, and so on and so forth from there. However, what I will say is both the order and the timing of when you get your teeth has a very huge genetic component to it. So if you had your teeth very early, chances are your kids will have your teeth very early. Chances are your mom had her teeth very early. If she got hers very late or got the lateral incisors before the central incisors, right? So that there's a strong, strong genetic predisposition to the order and arrangement of which the teeth come in. But for most people, all the primary teeth come in by about 2 years of age. 10 on the top and 10 on the bottom. Then, usually starting around age 6 or 7, we start to lose those baby teeth. And as we lose those baby teeth, our permanent teeth start to come in. Basically, the teeth buds start growing upward. And as they grow upward, they deteriorate the root of the tooth underneath. And then that tooth falls out and is replaced by the teeth underneath. Right. Again, we have that adult formula that we see here, 2 incisors, 1 canine, 2 premolars, and 3 molars all coming in. And notice they all come in starting from around age 6 or 7 up to the age of 17 to 25, which is when we get our last set of molars typically starting to come in. And those last set of molars you get in your extended old age of 25, which is why we call them our wisdom teeth, because at that point you are old and wise. All right. Questions on that?
If you take out your teeth a little bit late, does that mean they will be more crooked? That's what I think.
So you mean when the baby teeth come out?
Yeah, so if you take them out earlier, it's more likely that your teeth will be more straight.
So I wouldn't say that. I would turn it the other way. I would say that if it takes longer for the tooth to come out, then there is probably a little more likelihood of crowding, and that crowding can cause some displacement of the teeth that way. But that doesn't mean that as soon as a tooth starts wiggling, you should reach in there and grab it and yank it out for the kid, because again, that could be a bit painful. One of the interesting things they've looked about is, we talk about microevolution in a lot of other species, like, cats and dogs and things along those lines. But there's been a lot of speculation that there's been some microevolution in the anatomy of our jaw as well as humans. And so one of the problems is that the overall size of the mouth is shrinking. And so that's one of the reasons why you're getting a much more impacting of teeth, and the wisdom teeth more commonly need to be pulled as a result of that, because there's just not as much room in there as there was evolutionarily before. So there is some speculation on that. So if that were accurate and true, then yes, there would be some benefit for having the teeth removed early. But like I said, I'm not encouraging anybody to take their kids to the dentist and say, yank out these teeth so I don't have to pay for braces. All right. But it's a great question, yeah. All right, questions on that? All right, excellent. The last thing that I want to mention as well before we get into the physiology is as we exit the oral cavity, remember we talked about the boundaries of the oral cavity in the last class. We said that it is continuous with the pharynx. The pharynx is that muscular tube that we commonly refer to as our throat. And that muscular tube is divided up into 3 regions. And those 3 regions are basically defined by the openings that they are associated with. The superior part of the pharynx is continuous with the nasal cavity. Notice, remember, that's where we saw that flap where the auditory tube comes to the middle ear. Here's that pharyngeal tonsil that we talked about. And this nasal pharynx, remind me again, is lined with what type of epithelial tissue? What type of epithelial tissue do you think lines the nasopharynx? Not a bad guess. And that will be the correct answer to the next time I ask it, but that's not actually the case here. Simple columnar is not a bad guess either. But remember, that only starts from the esophagus down. This one, remember, is adjacent to the nasal cavity. So that means it's probably lined with the same type of tissue you would find in the nasal cavity. And what type of tissue, what type of epithelial tissue would you find in the nasal cavity? If only I had learned my epithelial tissues in 430. Close. Not necessarily the kind with villi, but those other finger-like extensions that stick up from the top. They weren't villi, they were... Apparently you all...
The pseudostratified one.
There you go. The pseudostratified one. Excellent. That gets us started. All right, so... Whoops. Where? Oh, I wrote it there. All right. Pseudostratified. Give me the rest of it. Because if you just write pseudostratified on the exam, you're only going to get partial credit. So give me the rest of the name. Come on, I know you know it. Ciliated. There you go. Columnar epithelium. Excellent. A pseudostratified ciliated columnar epithelial tissue. Excellent. All right. Notice the middle part of the pharynx, the oropharynx, is adjacent to the oral cavity. So what type of epithelial tissue might you expect to find there? Now you can say it, Eric. Excellent. A non-keratinized, stratified, squamous epithelium. Excellent. And then the laryngopharynx is the inferiormost portion of the pharynx, the portion that is adjacent to the opening to the larynx, right? And there's that epiglottis that we've talked about and we'll continue to talk about today. And this is also lined with one of those 2 tissues. Which of those 2 tissues do you think lines the laryngopharynx? Well, you got a 50-50 shot. Guess one. There you go. Excellent. Also a non-keratinized stratified squamous epithelium. Oh, where'd that go? I wrote it over here by mistake. Cut. Paste. Excellent. Why? Why the differences? Why is the nasopharynx associated with a pseudostratified ciliated columnar epithelial tissue, but the oropharynx and the laryngopharynx are non-keratinized stratified squamouses? Why the difference? Well, but these are all mucous membranes. They're all open to the outside world, so they all can have mucus associated with them. So that's not a bad guess. Okay, excellent. We know the nasal cavity and the nasopharynx have that ciliated pseudostratified columnar epithelial tissue because it is protecting us from inhaled pathogens. So that's a good point. What passes through the nasopharynx? Air. Exactly, it contains air. So we want that mucus and captured dust debris, move it to the back. What passes through the oropharynx and laryngopharynx?
Food.
Excellent. Food, drink, and air. All right, food, drink, and air. So notice in this case with the oropharynx and the laryngopharynx, we can't just, yes, air passes through those on their way to our lungs, but this is also a passageway for hot coffee. This is also a passageway for sharp tortilla tips, for acidic wine, right? For all sorts of other spicy foods and things along those lines. So our oropharynx and laryngopharynx need that protection. Should food be going up into your nasopharynx?
Should not.
Should not. However, when someone makes you laugh while you're drinking a glass of soda or something like that, can that air force food or spaghetti or drink up into your nasal cavity?
It can.
Yeah, it can. And is that an enjoyable experience when that happens?
No, don't.
No, typically not. Exactly, because food's not supposed to go there. So absolutely. So the reason we see the difference in the epithelial tissues is because of the differences in the substances that are contained there. All right. Now, real quickly before we get back to it, the pharynx. We talked about the mouth and we talked about all of the functions of the mouth. And if you think about the 6 or 7 functions of the digestive system, the oral cavity did all of them but one. How many of those functions of the digestive system does the pharynx do?
All but 2.
Okay, not a bad. What would the 2 be?
Ingestion and defecation.
Oh, okay. Okay, I like that. I like that. Now, do you think the food is in the pharynx long enough to really be mechanically broken down or to absorb anything?
Doesn't that peristalsis process break it down a little bit?
Yes. Okay, so here's what I would say. Technically, yes, some of those contractions could help to impact or modify the food that way. But I think you've got the right idea. I think the key with peristalsis is propulsion. Any other impact is going to be incidental. So I think you've hit on the key, is that really the pharynx's sole function is propulsion. Right? It is not going to play a role in any of the digestive functions. It's not, there isn't any major secretions other than maybe some mucus that is being produced there. So the only thing it is doing is propulsion. Essentially, it's a conduit. Right? It's a piece of PVC pipe. Its job is to carry the food. And remember, what we say the condition of the food is, the iteration of the food by the time it reaches the pharynx. What does our food become again?
Bolus.
A bolus. Excellent. It's become that bolus. Really, the sole function is to be a conduit for that bolus, to get the bolus from one place to another, from the mouth into the esophagus. All right. So with that in mind, open here some more pretty pictures showing this thing as well. Let's talk about that process of swallowing our food. Of course, we're not going to use a common term like swallow. What did we say the appropriate anatomical term was? Deglutition, excellent. Deglutition. Deglutition is an elaborate process involving 22 muscles. It is a subconscious reflex. What does that mean? Yep, we do need to know the epithelial tissue. Sorry, we do need to know the epithelial tissue of the esophagus. We'll get to the esophagus. We haven't gotten there yet. So we will absolutely need to know that. Well, so true. Part of it is that absolutely you're not consciously controlling the 22 muscles. So you're not actually thinking of which muscles you are using and how you are using those muscles. Not like when I lift this pen, I have an idea of how I'm doing that. You don't fully understand how you do that. But here's the other key to this as well, right? When you and your buddies are, out drinking on Friday night and have had too many Long Island iced teas and they're passed out and they're your designated driver. If they're passed out on the table, is the best thing to do to get a nice cup of warm coffee and pour it down their throat? No, because if you are unconscious, can a subconscious reflex take place? No. And so what's going to end up happening is you're just going to pour that scalding hot coffee into their lungs, which I promise you is not a good thing to do. Right. Excellent. So again, this is a subconscious reflex. You have to be conscious to do it. But again, we are not thinking of it necessarily as voluntarily controlling these muscles. There is a voluntary act to it, and we will talk about that in just a minute. And this process of deglutition occurs in 3 phases. And primarily, the phases are named by where the food is. This is actually going to be a concept that we're going to see as well. Well, but so being asleep and being unconscious are not necessarily the same thing, right? If you're asleep and someone shakes you, you can wake up. So there are subconscious reflexes that will take place when you are asleep. But if you are passed out unconscious, then no, then those reflexes will not take place. All right. So this concept we're going to see again, these phases are named basically on where the food is. So let's talk about these phases. Swallowing. Swallowing occurs in 3 phases. The first of them is basically starts with obviously the voluntary reflex of ingestion, putting the food in the mouth. And then once the food is in the mouth, we involve the buccal phase, the formation of the bolus, right? Mastication with the teeth, using the tongue to present the food to the teeth for mastication, mixing it with the saliva. All of this occurs to, again, transform our food into a bolus. Oops. So again, we are doing some chemical breakdown. We are doing some mechanical breakdown, right? We're using our teeth and our tongue to break the big pieces into small pieces. We're using our salivary amylase so that we can start to break down the carbohydrates, and mixing the food with the mucus to make it a slippery, slimy piece of mass. And that mass is what is known as a bolus. Once we form that bolus, then the job in the buccal phase is to, again, do the second voluntary act. And that second voluntary act is to present the food to the posterior part of the oral cavity. Now, I say that this is a voluntary act, but this is the kind of thing where if you're chewing a piece of gum or sucking on a hard candy and it goes back too far into your mouth, you can accidentally swallow it without even meaning to. Right? The reason for that is when we present the bolus towards the oral pharynx, it comes in contact with those arches we talked about, right? The palatoglossal Palato-glossal. And the palatopharyngeal. Arches. And when it comes in contact with those arches, coming in contact with that arch is what triggers the subconscious reflex. So again, sometimes if sucking on a piece of gum or chewing a piece of candy goes back too far, you accidentally swallow it. And the reason for that is it came in contact with the arches, and that triggered that swallow reflex. Now, notice one other thing that happens when we're presenting it to the oral pharynx. As that food is presented towards the posterior portion of the oral cavity, towards the oral pharynx, it pushes against the uvula, and that uvula elevates, blocking off the nasal pharynx. And that stops the food from going up into the nasal cavity. Right? That's really the key with all of this. The key to all of this is we want to make sure that the food goes one place and one place only, into the esophagus. That is our goal. So the first step towards that process is coming in contact with the posterior part of the oral cavity, which elevates the uvula and triggers the swallow reflex by coming in contact with those arches. All right, questions on that? All right, now put your hand on your throat and swallow. What do you feel when you do that?
It's moving.
Yeah, it moves. That little bump in your throat moves up, right? Anybody know what that bump is? It's this thing right here. Not a bad guess. It isn't actually the glottis. The glottis is actually the opening of the larynx. I think what you may be meaning is the epiglottis, which is this structure here made up of elastic cartilage. But no, the bump is actually what we commonly think of as the Adam's apple, is actually what is known as the laryngeal prominence. You have a piece of cartilage here called the thyroid cartilage because it sits right above the thyroid gland, and it has a bump on it that sticks out prominently. And that bump is part of the larynx. So what actually happens when you swallow is the larynx elevates. And the reason it does that is for two reasons. Let's switch, and actually let's stay here at this picture for a second. Let's take a closer look at what's going on, not so much over here in the oral cavity, but down here in the lower part of the pharynx. The default setting of our respiratory and digestive system is you're breathing all the time. So not surprisingly, the airway is open. One of the ways we see that that airway is open so that air can constantly be coming in is by having that elastic cartilage structure that we call the epiglottis elevated. So it's in an elevated state so that the airway is open. We actually saw this here. Let's actually, oh, I like this. I like this. Let's do this. Was it the endocrine? No, this isn't going to do it, is it? Stupid endocrine chart. Not what I want. Digestive chart, I bet. Wait, it's not there either. Where did we find it before? Respiratory? There we go. Here's a picture we've seen before. Remember, we saw the thyroid gland and the parathyroid glands on this here. But notice now we're looking at it from a different point of view. What they've done, this is a posterior view of the body. And what they've done is they've cut open the pharynx. So by cutting open the pharynx, we can see the portion where we are able to go and enter into the nasal cavity. And in fact, this little piece of chewing gum up here at the top is our pharyngeal tonsil. There's the uvula, there's the tongue as we're looking from the posterior view. And this is what I want to show you right here. This structure, this flap-like structure that sits up is the epiglottis. It is made up of elastic cartilage, and it covers the opening to the air hole, which is this opening right in here, where it would continue down into the cavity. We also saw this, and hopefully they will show it to us here. Excellent. So again, this back here, this collapsed muscular tube is the pharynx. Here we see the glottis, the opening, and again, here is the epiglottis that is going to sit over the top. Okay, so we have that, we have that. The other thing down here, inferior into the esophagus, we see, as we come back to this picture, that while the epiglottis is up and the airway is opened, the muscular tube that is the esophagus is closed. It is closed because there is an enlargement of the circular muscle layer within that region, forming a valve-like structure. What do we call valve-like structures, enlargements of the smooth muscle?
Sphincter.
Sphincter, and this is the upper esophageal sphincter. This upper esophageal sphincter is going to be closed in our resting state, whereas our epiglottis is open, or is up, let's say it that way, and our glottis, which is the hole, is open. This way, air can freely move into and out of our airways, but things aren't randomly going into our esophagus. However, then that food gets pushed to the back, closes the soft palate, and comes in contact with the arches. And when it comes in contact with the arches, it triggers our pharyngeal phase. And notice in our pharyngeal phase, as you felt, your larynx elevates. And when your larynx elevates, two things occur. Notice, because that epiglottis is made of that rubbery elastic cartilage, the same stuff you have in your ear, it basically bends over the top. So the epiglottis bends over the glottis and closes the airway. So now notice our food cannot go into the nasal cavity. Our food cannot go into the airway. But the other thing that happens when the larynx elevates is that it opens the upper esophageal sphincter. So while the food cannot go into the nasal cavity, cannot go into the airway, now the muscular tube that is the esophagus is open, and the food is able to travel down into the esophagus. So here, again, that tactile contact with the pharyngeal arches triggers the swallow reflex. It is a subconscious reflex controlled by the medulla oblongata, elevates the larynx, and that does two important things. It bends the epiglottis over the top, closing the glottis, closing the airway, and it opens the upper esophageal sphincter. And then, of course, it is going to undergo peristalsis, to move the food into the esophagus. or move the bolus. And that is the pharyngeal phase of deglutition. Questions on that? All right, excellent. Of course, once the food reaches the esophagus, then not surprisingly, we reach the esophageal phase. And when you felt yourself swallow, the larynx doesn't elevate and stay there forever. It elevates and then it descends. And that's exactly what happens here. Our larynx then descends. And when it descends, notice those two things that were just done are undone. The epiglottis raises again, and that opens the airway. And our upper esophageal sphincter closes. So the food can't go up. It is now trapped in the esophagus, and the esophagus is going to, again, use peristalsis to move the food towards the stomach. Notice, like the pharynx, the esophagus is also basically just a conduit. It doesn't absorb, it obviously doesn't ingest or defecate. There is no enzymes that are produced and released here. And again, any churning of the food is strictly incidental. Its sole function is propulsion. So again, the esophagus is again just a conduit. Whoops, I wanted that. Where it serves no other function but movement for getting the food from the mouth, from the pharynx to the stomach. Again, takes a handful of seconds for the food to get down there. Not surprisingly, like many of the organs we're going to see in the alimentary canal, there is a sphincter at the proximal end, and there is a sphincter at the distal end as well. This sphincter at the distal end, if this top one is the upper esophageal, not surprisingly, the bottom one is the lower esophageal. Oh, I don't like the black for that. Lower esophageal, but it is also called the gastroesophageal sphincter because it is the sphincter between the stomach, gastro, and the esophagus. It is also sometimes referred to as the cardioesophageal, because as we will learn, the proximal part of the stomach is what is known as the cardial region. Yeah, just a handful of seconds to get through down the esophagus into the stomach.
How do you want us to call the lower esophageal sphincter?
Again, you are welcome to use any appropriate anatomical term, and all three of those are appropriate anatomical terms. Cardioesophageal, gastroesophageal, lower esophageal sphincter, they all mean the same thing. They are enlargement of the circular layer of the esophagus at the opening to the stomach. I wouldn't necessarily say that liquids aid in peristalsis. Obviously, liquids are easier to flow down. I think that the moister the bolus is, typically the easier it is going to be swallowed. So if you're not able to mix enough saliva with it to lubricate it, to add that mucus, liquid can definitely help to facilitate that. So I would say, sure. So I would say liquids, sure. I think that that's a simple way of saying that liquids do aid in peristalsis. I would say that's reasonable. All right. And again, we had these pretty pictures. I've got one more pretty picture that shows this process as well. Again, here we have the oral phase, making the bolus, presenting it to the posterior part of the oral cavity. which is going to close off the soft palate, leading to the pharyngeal phase. When the larynx elevates, the epiglottis closes, the esophagus opens, and then our esophageal phase, where the food is expressed into the esophagus and travels down towards the stomach. Here we see a nice illustration of the esophagus. Again, it is a muscular tube. It is similar in anatomy to what we saw as the typical. So if we think about this, and let's make this easy. Here is the innermost layer. What would this innermost layer be? Closest to the lumen?
Mucus.
The mucosa, absolutely, that would be the mucosa. However, in this case, what epithelial tissue would it be in the proximal part of the esophagus?
Stratified schema.
Yeah, non-keratinized stratified squamous epithelial tissue. Excellent. Deep to that, we have our submucosa, which is areolar connective tissue. Deep to that, we have our muscularis with a circular layer and a longitudinal layer. And deep to that, what would this layer out here be?
Connective tissue.
True, but what would we call it? Ah, there you go. Alexa's got it. Adventatia. Why isn't it a serosa, Alexa? Or anyone? True, it's not in the peritoneal cavity, right? In fact, remember the esophagus is retroperitoneal. Technically, if you think about it, the inferior part of it is in the peritoneal cavity. It has to pass through the diaphragm to get to the stomach. In fact, I think we see a nice opening to that here. Hold on, let's go back to the charts from here. So I don't think this is going to show it. So hold on, let me go to the digestive because I think the digestive showed it nicely. No, not the top model. Wrong button. There we go. Notice right here, we see the diaphragm, right? It's pushed up a little bit because the liver's shoved up. But what we can see is this nice opening in the diaphragm where the esophagus has to come through. Any idea what that would be called? What would we call that opening in the diaphragm that the esophagus passes through? If only I had a list of the anatomy I was responsible for in this class. Excellent. Alexa's barely got her list out. Esophageal hiatus. Excellent. Notice the other thing I really like about this illustration. The other thing I like about this illustration is notice here they have emphasized our sphincter, that lower esophageal sphincter, the cardioesophageal sphincter. The sphincter is not the diaphragm. The diaphragm is not what restricts the flow. There's a hole in the diaphragm, the esophageal hiatus that the esophagus goes through. Then after it passes through is where that sphincter is that is going to regulate the flow of food into the stomach and also, hopefully, stop food from going back into the esophagus. What do we call that condition where food from the stomach goes back up into the esophagus? Okay, yes, the emission of it would be vomiting, or could cause damage or heartburn. But what is the appropriate term for it? What causes that heartburn?
Acid reflux?
Yeah, acid reflux, exactly. Well, it's reflux where it goes back up, and because the contents of the stomach are acidic and the esophagus doesn't have the same protections that the stomach does, then it's going to be damaging to that and typically causes that acid reflux, which can be painful, causes that heartburn that we associate it with. So when you breathe, the diaphragm moves along the esophagus through. I wouldn't say it moves along the esophagus. I would say that it pulls the esophagus down. Remember, the esophagus isn't a muscular tube, so it can probably be extended as well with that. Yes, and in some cases, although it doesn't as much commonly occur in adults, but you're absolutely correct in that what can sometimes happen with newborns is that the diaphragm doesn't seal fully. And so what happens is the small intestine or portion of the stomach or things like that are able to express themselves into the thoracic cavity in a condition they call a hiatal hernia. And that can be incredibly dangerous because obviously the more things you crowd into the thoracic cavity, the harder it is for that baby to breathe. It can also put pressure on the heart and have problems that way. So often things have to be removed. It has to be surgically closed. Scary, dangerous condition that can happen to your babies, but it is something that if caught early enough can be treated. All right.
Is the only function of this just the opening into the diaphragm for the esophageal hiatus?
Yes, the esophageal hiatus is the opening in the diaphragm that the esophagus passes through. So it's the doorway in the diaphragm. You have to have that doorway to get into your house. You have to have this doorway for the esophagus to get to the stomach. The other thing that I would like to point out to you from this illustration is the histology over here. Remember, one of the things that we keep emphasizing is that the anatomy of the esophagus for the anterior 2/3 is different from the anatomy of the distal third. So the proximal 2/3 is different than the distal third. The proximal 2/3, like we see in this illustration, contains a non-keratinized stratified squamous epithelial tissue. However, just prior to reaching the stomach, there is a change in the epithelial tissue where it becomes simple columnar and continues simple columnar all the way to the rectum. And what I love about this picture is you see that it is not a gradual change. The two tissues are butted right up against each other. You have that non-keratinized stratified squamous epithelial tissue, and then boom, it instantly transitions into a simple columnar. And it can be seen very, very clearly. The other picture, and in fairness, this is a rat, as far as I can tell. It's either rat or rabbit. I'm not 100% certain which. But what we can see here is that pyloric sphincter, the stomach, right? These are what these sphincters look like. This is one from the stomach into the small intestine. But what I wanted you to see from this is that, again, we have our normal muscularis, but then what happens is we get this huge enlargement of the circular layer. And this huge enlargement of the circular layer is what forms that valve that is going to be able to regulate the flow through the organ. So sphincters really are these massive enlargements of the circular layer of the smooth muscle of that muscularis. Now, again, like I said, this is at the end of the stomach, but I was throwing these pictures together quickly and I just wanted to show you what a sphincter looks like for that. All right. Questions on that? No. Great question. No, this tissue here. This tissue here is simple columnar. Notice, again, there are microvilli, so I could see where you'd think it might be cilia, but remember, these have microvilli on the surface of them. But notice their nuclei all line up. The cells themselves are very uniform. And remember, as we talked about, the basic anatomy of most of our alimentary canal is a simple columnar epithelial tissue from the posterior or distal third of the esophagus all the way through the rectum. Great question. So those who eat the hot dogs, I wouldn't say that they necessarily have a stronger esophagus, although I guess it is possible that they're able to work those. I definitely think that they have a relaxed gag reflex. And then the other big thing that they have to do, it's not so much the esophagus that they have to worry about fixing and extending, it's the stomach. So one of the things they will do is they will drink, a gallon of water just to stretch out the stomach and expand the stomach so that it is able to accommodate the food that they're able to. It's one of the interesting things about these competitive eating things. You're surprised sometimes by the number of relatively small guys who are able to do it. In fact, before Joey Chestnut started winning for the USA, Kobayashi was the reigning champion, and he is just this tiny little Asian guy. But one of the things that can happen is if you have a lot of excess body fat, then that excess adipose that accumulates can influence the ability of the stomach to be able to stretch and swell. So actually having a smaller frame can give more space for that stomach to be able to be expanded. So they do a lot of water training to expand their stomach to be able to accommodate that massive amount of food.
Could you please explain again the gut reflex, how it goes?
I'm sorry?
Could you please explain again the gut reflex?
Well, so the gag reflex is a protective reflex so that as substances are forced towards the posterior part of your oral cavity, you don't want them going into your airways. So it is a protective reflex for your airways that if something goes too far back and you're not trying to swallow it, that it can cause that gagging because, again, you want that forcing of the air to stop whatever that substance is from going into the airways.
But it provokes vomiting, right?
No, great question. So gagging can sometimes lead to vomiting, but so can excessive coughing, so can excessive laughing. In those cases, what happens is the contractions of the abdominal muscles squeeze the stomach so much that squeezing of the stomach can cause pain and pressure receptors in the stomach to cause that vomiting to occur as a result of that. So it's more the excessive coughing, the excessive pressure on the abdomen that causes the vomiting in that situation.
Okay, thank you.
Yep. All right. Any other questions on this? All right, excellent. We are now finally done with the mouth and get to move on to the stomach. But I think this is a nice, good transition point. So let's go ahead and take our first break here. It looks like it's 1:08 now. So let's go ahead and go to 1:23 and we will restart at 1:23. All righty. Any questions on that? All righty. Let us talk about the stomach. We've talked a teeny bit about the anatomy of this so far. We know that, as I've already mentioned, there are two surfaces to it, a concave surface that we call the lesser curvature, and a convex surface that we call the greater curvature. So we have those two curves to it. We mentioned that it is bounded by valves on both sides. We have a thickened region of the circular layer that is that cardioesophageal or gastroesophageal or lower esophageal sphincter that feeds into it on the proximal end. And there is an enlargement of the circular layer that they actually show for us here, known as the pyloric sphincter. That is the exit point for the stomach. The stomach itself is bounded or divided into three regions. We have the cardial region. The cardial region is the part up here that is closest to the heart. And again, gets that name because as we talked about with that acid reflux, it feels like you have heartburn. So that is that region there. We have the pyloric region or the pylorus. That pylorus region is basically the funnel-like region that feeds into the small intestine. We have the enlargement, this big, huge enlargement that comes off the top is the part that is the fundus. and then the rest of it is the body. So we have those 4 regions. Stomach, retroperitoneal or intraperitoneal? Intraperitoneal, excellent. So that means it is bounded on the outside by a serosa. Of course, the inside is lined with a mucosa. Then we have a submucosa and a muscularis. Again, the stomach smack dab in the sweet spot, so we know the basic anatomy of it. However, what I would like to point out to you is that there are a couple specializations to the microscopic anatomy of the stomach, starting first with the muscularis. Notice, as expected, we have a longitudinal layer where the fibers run the length of the organ. We have a circular layer where the fibers go around the circumference of the organ. But with the stomach is the only region of the alimentary canal that has a third layer of smooth muscle. That third layer is at an angle to the other 2. So not surprisingly, it is called the oblique layer. And notice that oblique layer is the one that is closest to the lumen. What's the advantage of having 3 different layers of muscle at 3 different orientations? Come on, guys. I'm here for you. This is college. You're adults. Again, if you guys want to have your cameras off, that's fine, but you need to be interactive. Don't make me be like my kids' school where they're forced to be on the camera all the time to get them to interact. Don't make me do that. Answer the questions when I ask them so we can all be grown-ups here. Excellent. It allows for more dynamic churning, right? So it allows for more different motions, more motility, right? As we talked about, I know everybody in this class chews their food the 25 times before they swallow it, but if somebody doesn't, then luckily the food can be continually mechanically broken down by this very dynamic stomach because it has those 3 layers to them. There are a couple other specializations. One we see here in the gross anatomy, and that is all of these folds. Notice that the membrane on the inside isn't smooth. There are folds in the membrane known as rugae. Basically, the stomach is a collapsible sack, right? If you were to take one of those paper bags from the shopping bags from, Safeway and clump it down, you could, collapse it down into something the size of your fist by basically forming all these folds in it. And that's what basically has happened here. One of the important things to remember, we'll talk about that in a second. One of the important things to remember here is that the rugae are formed by both the mucosa and the submucosa. So both the mucosa and the submucosa have folds in them, but not the muscularis that surrounds them. And I believe I have a slide, excellent, that shows this. So here we have a very low magnification view of the stomach, right? So again, we have our muscularis that is here. Notice we can see the muscularis mucosa that is located here. And that of course tells us that this part here is the mucous membrane and this part here is the submucosa. And so notice these big, huge folds that stick up are made of both the mucosa and the submucosa. And so these rugae are formed by those 2 layers together like that. All right. Excellent. So when someone gets a gastric bypass surgery, typically there's a problem with the stomach. It could be ulcers, it could be cancer, it could be things along those lines. And basically what they do is basically whoops, that doesn't work. Basically, they have a tube that they basically feed right into the duodenum. And they really do that for 2 main reasons. One of the reasons they do that is, as it turns out, the stomach isn't vital, right? If you randomly grab somebody on the street and ask them to identify a muscle in the digestive system, most people would say stomach. Its stomach definitely has rock star status, but it's not very deserving of that rock star status. right? As it turns out, there is nothing that it does that is vital for your existence as a person, except one thing, and it isn't the one thing you think it is. Everything the stomach does, with one minor exception, isn't vital for the function of the digestive system. Does it make it easier? Absolutely. If you get a bypass surgery, do you get to feed cheeseburgers into that tube straight into the duodenum? No, the food has to be a little bit more processed before it can be put straight into the small intestine. But again, there isn't really anything that the stomach does that is vital, like I said, except for one minor exception. So the true rock star functionally is the small intestine. So we want to make sure the food gets in there. The other reason they'll do it into the duodenum instead of into the stomach is because if you're feeding a bunch of food in a tube into the stomach, that could increase the pressure of the stomach. And depending on what's causing the problem of the stomachs, you don't want that food, right, reversing back up into the esophagus. So we don't want the damage to the esophagus. We don't want the regurgitation that can take place, right, from the pressure that causes that. So again, it can be dangerous that way. It can even cause choking if it gets too far up. So it's protective that way so that it stops the food from going back up into the esophagus. And it's because the stomach isn't doing anything vital. Like I said, it only does one thing that's vital that you can't live without, and it's not the thing you think it is. Yes. So there are anecdotal evidence of stories of people rupturing their stomachs. Sometimes, rarely from eating a massive amount of food. Just because it's hard to get that much food in there. However, what often will happen is someone will take, or at least the anecdotal story is someone will take and eat a massive amount of food and then will eat like some baking soda because their stomach is upset. That increased pressure is causing heartburn. So they take something like a baking soda to try to neutralize the acidity. Well, of course, as you know, when it neutralizes acidity, it produces gas. And that gas can cause problems where it increases and can cause the swelling. However, I think it was Mythbusters once with a pig stomach did a study to see just how much pressure they could put into the stomach before it ruptures. It isn't something that is going to be very easily to do. So it takes a tremendous amount. So yes, so you're correct. They can do things like a stomach stapling, where they will actually staple off a portion of the stomach to limit the size of it, or they will also do stomach banding, where they will put a band around the stomach, narrowing the size of the stomach. And the goal of those things are usually extreme weight loss type of activities. And the goal is to limit the overall storage size of your stomach to limit how much that you can eat. So if you try to eat more than can fit in the decreased size of your stomach, that can cause trouble, that can cause regurgitation, that can cause problems. And so basically, it's a way of trying to force people to eat less. However, when you took to most people, yes, and the older surgeries, like the stomach stapling surgeries, are not something that is easy to reverse. And that's one of the reasons why they use the banding. With the banding, it is something that they can adjust, and I imagine they can take off as well. But if you ever talk to anybody who's ever had one of these surgeries, they learn tricks to be able to get around it. And so it really doesn't modify people's eating behavior as well as you would think that it would. And again, it's like we talked about, there's so many other driving forces that lead us to eat, whether it is emotion, whether it is boredom, right? When we're happy, when we're sad, depressed, right? Bored, whatever it is, as well as just the times of the day, social pressures, right? All sorts of things cause us to eat when we are not necessarily hungry. So, but yes, the bandings can be. I don't think the stapling can be, but I'll be honest, it's a pretty older process and I don't know as much about it. All right, those are some of the specializations we can see from the gross anatomy view here. However, if we look up close at that mucous membrane, we can see one of the other major specializations to the stomach. And that other major specialization to the stomach are what are called the gastric glands and the gastric pits. Notice here again and again, notice the one thing I don't like about this picture is they're showing you rugae on the surface and trying to show that these are the rugae. This is not the rugae. Notice the submucosa is not a part of it. So this is just the irregular surface of the stomach. As you look at the surface of the stomach, what you will see is that the surface of the stomach is not flat. There are all these major invaginations. These invaginations basically have two parts, and I think the illustration over here, when we look at one of them, shows this the best. So notice we have the outer surface of the stomach, and then this invagination. This invagination of it is known as the gastric pits. Notice in this gastric pit, this fold in the mucous membrane. And again, these gastric pits and gastric glands are just in the mucous membrane. Notice they are not a part of the submucosa. Are all lined by the same types of cells. Those simple columnar epithelial cells and goblet cells. And these goblet cells basically produce mucin. Right? These are our mucus cells. They produce a very thick and a very alkaline mucus. And what is the function of this thick alkaline mucus? Thick, sticky, alkaline mucus. Right, to protect the stomach, absolutely. As we know, the gastric juices in here are going to be very acidic, right? Not to mention all of the horrible things we're putting into our body food-wise. So we need to protect the lining of our stomach. So we have this thick, sticky, alkaline mucus that coats the surface, the lumen of our stomach, and it is produced by the mucus wall and the gastric pits. However, notice deep to the gastric pits, there are all these specialized cells. And these specialized cells are located in the special structure called the gastric gland. And it is the job of the gastric gland to, to produce our gastric juice. And as we can see nicely from this illustration, there are primarily 4 types of cells that are found inside of our gastric gland. Let's take a look. Here is again another illustration that shows this, the gastric pits up here at the top and then the gastric gland here below. Yet another nice illustration that shows this. And again, as we talked about at the top, we just have our normal goblet cells. They line the surface of the stomach, they line the gastric pit, where their job is to produce that thick, excuse me, that thick, sticky, alkaline mucus to protect the stomach. All righty. But deep to that, we have those specialized cells, 4 specialized cells that are involved in the production of our gastric juice. Now, and this is going to be something I'm going to say many times during these lectures. The volume actually depends greatly on the number of times you eat, the volume of food you eat, and the type of foods you eat. But on average, an individual produces about 1.5 liters of gastric juice in a 24-hour period of time. And like I said, there are basically 4 cells involved in this production. The first are what are known as parietal cells. These parietal cells, as we can see from the illustration, have a very distinct shape to them. They have this kind of pitchfork type shape to them in the way they formed. Now, this is the way they look under the microscope. This is the actual shape of them, and it is a shape you should be able to recognize. But if we actually look at this histologically, are you actually going to be able to distinguish? Are you going to actually be able to distinguish this shape? What do you think?
We should.
No, you
Oh.
should. Well, you should, but I'm not going to hold you responsible. The same way I didn't hold you responsible for the alpha and beta cells. I didn't point at one of those cells under the microscope and say, what type of cell is this? But did you need to know what the alpha cells did? Did you need to know what the beta cells did? Absolutely. And it is the same way here. You're not going to have to recognize a parietal cell under the microscope, but you absolutely need to know what it does. What our parietal cell does is it is the cell that produces the hydrochloric acid. What does that hydrochloric acid do for us? So which one? Mechanical or chemical breakdown? I've seen both. Breakdown of food, chemical breakdown. So chemical breakdown is where you break bonds. Does hydrochloric acid break bonds?
It activates enzyme pepsin.
True. You're right. One of the things it can do is activate enzymes. But then it would be the enzymes that are chemically breaking things down, not so much the hydrochloric acid. How does hydrochloric acid activate enzymes?
With its acidity.
Okay, but what is it about the acidity?
Oh.
If only I understood how pH affects proteins.
It destroys them.
Destroys what kind of bonds?
Peptide.
Nope. Hydrogen bonds, absolutely. Proteins are sensitive to temperature changes and pH changes because they're held together. They're given their three-dimensional shape by hydrogen bonds. If you change the pH, if you change the temperature, you can break hydrogen bonds and you change the shape of that protein. And what do we call it? It's the fancy word for changing the shape of a protein with temperature or pH. Denature, absolutely. You do it every morning with your eggs. You put that clear albumin into your pan and it fries up and becomes white, right? Because you are denaturing proteins. If you denature proteins, you are changing the shape of the protein, but are you breaking any bonds in that protein? No. So that indeed is mechanical digestion. Now, does that work for lipids? Does that work for carbohydrates? Nucleic acids? No, just proteins. It is the mechanical digestion of proteins only. So the mechanical digestion of proteins takes place thanks to that hydrochloric acid. It activates enzymes. And that hydrochloric acid does one other really important thing we talked about in the last section of the class. And what was that? Well, and I remembered what we talked about in the last section of the class. There you go. Protects us. And not just from bacteria, but from all pathogens. Most pathogens do not like an acidic environment. So it's protection. I don't know what protection is. Protection from pathogens. Excellent. All important things that it can do for us, that hydrochloric acid for us does. But as I mentioned, not vital. Makes things easier. Oops. Do I want to get rid of everything? Yeah, sure, I can get rid of everything. However, I did say there is one thing that your stomach does that is vitally important. And it is the parietal cells that do it. The parietal cells produce a very important hormone-like protein called intrinsic factor. And what intrinsic factor does is it tells your large intestine to absorb vitamin B12. You can drink a whole cow's worth of vitamin B12, but if you don't have this intrinsic factor, your large intestine won't absorb it. But that's not a big deal. All vitamin B12 does is allow you to make red blood cells. We have all the red blood cells we need. We don't have to bother making more, right? No, we absolutely have to make more. As we learned, red blood cells only last for 100 to 120 days. It is vitally important that we be able to make more red blood cells. So it is vitally important that we get B12 into our body. So it is vitally important that these parietal cells release intrinsic factor. If you have cancer of the stomach and the stomach is removed, if you have major bleeding ulcers of the stomach and the stomach has to be removed, then that's great. They take the stomach out, you will live, you will survive, but you are also taking B12 injections for the rest of your life because you're not going to be able to absorb it from your food anymore. So you have to take those injections intravenously to make sure that you are able to make red blood cells. So that right there is the only thing the stomach does that you cannot live without. All right, the second cell is our chief cells. And chief cells make an inactive enzyme called pepsinogen. It makes it in an inactive form because our chief cell doesn't want that pepsin, which is the active form, doing its job inside of us. Anybody know what pepsin is? An enzyme that breaks down? Proteins, absolutely. Pepsin breaks down proteins. So remember, we talked about how the breakdown of carbohydrates chemically started in the mouth. Our proteins start in the stomach, thanks to our friend pepsin here. Now, chief cells, bean cells, are chock filled with proteins. And do we want that pepsin breaking down the proteins inside of the chief cell? No, which is why it's not surprising that it's produced in an inactive form. That inactive form is then released into the gastric juice, where, as someone mentioned, the hydrochloric acid is actually able to activate the pepsinogen into pepsin. And then that pepsin can activate more pepsinogen into pepsin. So we get this beautiful positive feedback type of reflex going on here, where, again, that hydrochloric acid can activate pepsinogen into pepsin, and then that pepsin can help to activate more pepsinogen, making more and more pepsin, allowing us to break down our proteins. So these two work together so that we can start the breakdown of proteins in our stomach, which is also what our hydrochloric acid is doing. Remember, our hydrochloric acid denatures, unfolds the proteins, making it easier for the enzymes to get in there and start chopping it up. So it helps to facilitate the process. All right, now, chief cells have another function as well. In infants, our chief cells produce renin, which happens to be an enzyme that breaks down milk sugars, and gastric lipase, which helps with milk fats. Why might it be helpful to break down milk sugars and milk fats in that infant? Because that's all they eat, exactly. Absolutely. Right. One of the things that happens to all of us as we age is we become a little bit lactose intolerant. Part of it because we produce fewer of these types of enzymes. Also, we tend to produce less lactase as we age. So we all become a little more intolerant to milk as we age as a result of that. But again, as an infant, that's all we're supposed to be eating. So not surprisingly, we have a lot of that. And again, remember, Also in your stomach, that hydrochloric acid is going to activate our lingual lipase as well. So notice here in our stomach, we get the beginning of the breakdown of the breakdown of proteins, and also the beginning of the breakdown of our lipids as well. All righty, notice there are two other glands. These parietal glands and chief glands are kind of distributed through the middle region. So these are kind of interwoven within the middle region of the gland, the gastric gland. But there are other two types of cells here as well. At the proximal part, what's going on? There we go. Up at the superior or proximal part of the gland are these interesting cells called mucous neck cells. These are not the same thing as our surface mucus cells. These are a different type of mucus cell. So mucous neck cells. And what's interesting about them is they also, obviously being mucus cells, produce mucin, make mucus, but the mucus they make is acidic. Why it's acidic is not fully understood, but there seems to be two pretty prevalent reasons. As we know, pH helps to activate our pepsin, so it could play a role in helping to activate the pepsin in that fashion, that way as well. But notice also, these are at the proximal end, near the opening of the gastric pit, where we have that sticky alkaline mucus. So it is also believed that these mucous neck cells with their acidic mucus help to maintain the opening of the gastric pit, so that the gastric pit doesn't become congested with a big, huge chunk of alkaline, sticky mucus. So it may help to maintain the opening of the gastric pit as well. And then deep in our gastric gland, move this over here. Sorry, juggling my pictures a little bit. Okay, they may not be on your histology list, but absolutely you need to know these cells and know what their functions are. So I would say that. And again, none of these you're responsible for histologically. So none of these you have to be able to identify on a microscope. On an illustration like this, should be able to tell the parietal cell because of its funky shape? Sure. So something like that, or a model that showed it or something like that? Absolutely. But the fourth cell is one of those enteroendocrine cells. Remember, these are those single-celled endocrine glands. These are deep within the gastric pit, because if you think about it, if it is producing a hormone, is the job to release that hormone into the lumen and out of the body? No, remember, hormones are released into the interstitial fluid, where they're going to get picked up by the circulatory system and distributed throughout the body. And that's indeed what this enteroendocrine cell does. Now, this particular enteroendocrine cell is what is known as a G cell. It is called a G cell because it produces a hormone called gastrin. And gastrin basically does several things, but here in the stomach, what's most important is that it stimulates both the parietal cells and the chief cells. So as a result of this, we make more gastric juice. And it also stimulates the muscularis externa. So we get more churning of the bolus, more mechanical mixing, more mechanical breakdown of the food. So here in the stomach, and we'll talk about some of the other effects of gastrin in just a bit. But here in the stomach, the function of it is to make more gastric juice and stimulate the stomach to churn more, to break up more food. All right, questions on that? Here we have some histology to look at for this. Here we have a gastric gland. So if we're looking at the anatomy of this down here, here is, and again, one of the nice, easy things that are easily able to be identified on most of these digestive system histologies is you can find the muscularis mucosa. That's thin layer of smooth muscle that is going to distinguish the mucosa from the submucosa. So notice everything above this is the mucosa, and then everything below this to here so much is the submucosa. And then we see, well, actually, I guess a little less than that. I don't know if I can change that. Maybe I can. Put it here and move it up. There you go. And then we can see the beginning of our muscle layer down here. So we can start to see some of the smooth muscle in this layer here. And since we're only seeing one layer of the smooth muscle, what layer of the smooth muscle would this be? What layer of smooth muscle of the stomach is closest to the lumen? Oblique, excellent. So we can see the beginning of the oblique layer here. Now, notice up here at the top, on the surface and lining the gastric pits, we can see some cells that have some big goblet cells in them, right? The simple columnar epithelial tissue has big, huge cells filled with mucin. So we can see all those goblet cells lining the surface. This up here, this over here with the mucus cells the goblet cells are our gastric pits. Whereas, as you can see, all of this down here, here, and here, and here, and here, these are the gastric glands. Now, notice, you don't see goblet cells in this, right? We see clusters together. We can see some variations in color, some variations in size. And again, am I going to hold you responsible for being able to tell if this is a parietal cell or chief cell, or if that's a parietal cell or chief cell, and is that one a neck cell and all of that? No, I'm not going to make you do that. However, one of the things we do need to be able to distinguish is some of the regions of the stomach, because not all parts of the regions of the stomach are built the same. That pyloric region, the area that is the funnel out of the stomach, is the part where most of the strongest muscle contractions take place. And it's responsible for expelling the food into the small intestine, impacting that bolus, although it's not a bolus anymore. We'll talk about that in just a second, and spreading that food down. As such, the mucosa of its gastric glands contain much more goblet cells. It basically just produces mucus, where more the body and the fundus is where we're producing most of the gastric juice. So here, this particular mucous membrane we're seeing is the mucous membrane of the cardial region or the fundus region. Can you tell them apart? Yes. Am I expecting you to be able to tell them apart? No. But what you should be able to do is tell the difference between this and this. Again, this is a slightly different magnification, slightly different plane of section. But notice we can still see the glands of the gastric glands coming down. But notice the gastric glands now are much more uniform and much more clear, and there are a massive amount of goblet cells in here. In the pyloric region, the gastric gland produces almost exclusively mucus. So the gastric gland looks dramatically different in the pyloric region. Here is a lower magnification view of the pyloric region. Again, even at a low magnification, we can see how those gastric glands have massive number of goblet cells lining within them. And notice also, as I mentioned, the pyloric region has a really thick muscularis. And we can clearly see layer 1, layer 2, layer 3 of our muscularis. And of course, layer 1 closest to the lumen, what type of layer is that?
Oblique,
Layer 2, what's that?
circular,
And layer 3,
longitudinal.
there you go, perfect. And then the dark line you see on the outer surface would of course be the serosa. Again, notice we can't see the simple squamous epithelial tissue. We can't see the areolar connective tissue, but we know we're looking at the stomach. We know the stomach's intraperitoneal. So we know that layer right there has got to be a serosa, the visceral peritoneum. And because we know it's a serosa, we know it's made of a simple squamous epithelial tissue. We know it's made of an areolar connective tissue. We know the simple squamous epithelial tissue is a mesothelium based on its location. We know it produces serous fluid that we call a transudate based on its location, right? Because we could recognize this was the stomach and the 3 muscle layers was a dead giveaway that it was a stomach, and all the goblet cells is a dead giveaway we're looking at the pyloric region, we can tell from here what we're looking at and so much more. All right. Questions on that? So that is the anatomy. And let me actually do one more thing too. Since I mentioned it earlier, but let's actually move it here and show you again, just to emphasize the point. No, that didn't work. There we go. And at the distal end, we can see that pyloric sphincter. And again, notice the pyloric region, now that we've talked about it more, the pyloric region we can see has a much bigger muscularis than the small intestine. Again, even at a low magnification, we can kind of see the goblet cells in here, although not really as well. But again, that huge enlargement of the circular region, that is that pyloric sphincter. And then we just go to 2 muscle layers here. And we see one other special thing that tells us this is the small intestine here in the submucosa, but we'll talk about that later. And the villi and everything else, all the other fun things that we need to talk about for this. But this is the terminal end of the stomach, that pyloric sphincter. All right, questions on that? S is the suprarenal gland, or what is also known as the adrenal gland, right? So our adrenal gland sits on top of the kidney, so it is the suprarenal gland. Because add pucker doesn't sound as good.
So how we distinguish the enter and the exit of the stomach?
From that picture?
Yes.
Well, when we talk about the small intestine, so there are 2 simple answers to your question. The first is that this has 3 layers to its muscularis, so that must be the stomach. The second is these glands inside of the submucosa of the small intestine, and we'll talk about those when we get to the small intestine. But that would be that's a dead giveaway, the same way that the 3 layers to the muscularis is a dead giveaway.
Okay.
Okay, but we have to get to the small intestine before we can talk about that. And before we do that, now that we've done the anatomy of the stomach, we need to do the physiology. The same way that if someone were to chew up their food and spit it out in their hand and offer it to you, you wouldn't accept it because it looks different, because we've gone from food to bolus, right? When that baby swallows the food down and then spits it back up again, right? It looks different again as well. And that's because that bolus, when it gets continually mechanically broken up and mixed with our gastric juice, becomes our third iteration of food, and that is to form our chyme. So once the food reaches the stomach, it is converted into chyme, and it is then going to be that chyme that is presented to the small intestine. As we mentioned, when we talk about the functions of our stomach, it plays an important role in the mechanical digestion. Using all three layers of smooth muscle, it can produce elaborate, complex contractions to continue the mechanical digestion. And the fancy term we call for all those fancy contractions is churning. So that churning of the stomach helps in the mechanical breakdown. There is going to be some chemical digestion that takes place. What are the enzymes that are active in our stomach again?
Pepsin.
Pepsin, excellent. And what was the other one? What was the other enzyme that started in the bolus and wasn't active, but once it gets to the stomach, because of the pH change, is converted into an active form? Lingual lipase, excellent. Excellent. And then, of course, we have that secretion of our gastric juice, right? So excellent. We have those functions in there. We did that. We did that. We did that. We talked about that.
Isn't inactive form of pepsin pepsinogen?
No, pepsinogen is the inactive form. So pepsinogen is inactive. It is activated into pepsin. Pepsin is the active form.
Okay.
Yep. Now, not surprisingly, in the stomach, if you have a big, huge, thick, sticky alkaline over the surface of the cells, that is going to limit the food's ability to come in contact with our mucous membrane. So there is only going to be limited absorption that can take place. But there is some important absorption that can take place in here. Water, especially if it's cold. Why cold water gets absorbed faster than warm water, I don't fully understand. But cold water is definitely absorbed more rapidly than warm water is. Certain electrolytes can be absorbed, fatty acid chains, and alcohols. Some medicines like aspirin all can be absorbed in your stomach. It's one of the reasons why it is important to not have that third shot of Jägermeister on an empty stomach. Because if you're taking those 3 shots of Jägermeister and putting it straight into the stomach, it's going to get absorbed very, very rapidly. If you at least mix it with some food, that will slow down the absorption of it, and it'll have a little less kick. I guess unless that kick is what you're going for. If you're hoping to black out, then by all means, take 3 shots of Jägermeister on an empty stomach. It'll do it every time. All right. As we mentioned, there is that churning. And that churning is really more about mechanical digestion. But remember, we also want to do some propulsion as well. There is some peristaltic waves that are going to take place within the stomach, and they're continuously occurring in the stomach slowly at a rate of about 3 per minute. What's really cool about this is we actually have some pacemaker cells, similar to the pacemaker cells we found in the heart, that are located in the stomach. Remember, the stomach has this elaborate gut brain, and part of that enteric plexus are actually some pacemaker cells of good old Ramon E. Cajal, again, one of the most famous neuroanatomists on the planet, who put his name on a ton of things. And Cajal named these pacemaker cells, of course, after himself. They set up this basic rhythm of peristaltic waves within the stomach called the basic electrical rhythm, or BER. This basic electrical rhythm, as we mentioned, are these slow peristaltic waves that work their way through the stomach at about 3 per minute. However, when food is present, this is a stretch of the stomach, the pH, gastrin is released, then those contractions are going to become stronger, more rapid, and more powerful, with the goal of mashing that food, mixing that food, forming that chyme, and then expressing that chyme to our small intestine. Now, it depends on how much food you eat, the type of food you eat, but on average, the stomach empties in about 2 to 4 hours. All right, so you have breakfast at 7, and by the time you're having lunch at 11, your stomach's empty and ready for it. All right, questions on that? All right, we need to talk about the regulation of gastric activity. Right? Regulation obviously means control. And what are the two mechanisms we use for controlling the digestive system again?
Nervous and endocrine.
Yeah, nervous and endocrine. So we will talk about both hormones and neural control that is taking place. Now, again, obviously these control all parts of our digestive system. But when we talk about gastric activity, we are talking about the stomach only. So when we're talking about gastric control, we are just talking about how the nervous system and how the endocrine system control the activity of the stomach. Notice there are 3 phases. And notice also those phases, once again, are associated with where the food is. And notice also that all 3 phases have both stimulating effects and inhibiting effects that they can involve. So this is a fair amount of information. I think this is a good stopping point. So let's go ahead and take our second break. It is 2:12 right now, so let's come back at 2:27. And at 2:27, you will learn everything you ever wanted to know and more about how you control the activity of the stomach. All right, so any questions on that before we take our second break? All righty, let's go ahead and get started. So again, our goal now is to talk about the regulation of the gastric activity, how we control the events that take place in the stomach. And as we mentioned, there are 3 phases to this. And once again, the 3 phases are related to where the food is in the process. Starting first with the cephalic phase. What does cephalic refer to again? Head, absolutely. So really the key with the cephalic phase is it occurs before the food reaches the stomach. Essentially, the food is in the head. Now, there is the obvious where it could be in the mouth, where obviously if it's in the mouth, you are, among other things, tasting the food. But remember, this is also what we talked about, how our digestive system can be influenced things like smell, right? Just smelling the food before it even enters the alimentary canal, seeing the food, thinking about the food, etc. All of these functions are about getting things ready. So really think about it. This is about priming the system. Right? This is our way of telling our stomach, hey, food is on the way, get ready. Right? However, well, let's do it this way. First, if we are going to be priming the stomach in this fashion, right? And we know there's two ways we can control things, hormonally and neurally. If we're talking about the taste, the smell, the seeing, the thinking about the food, which of those two regulatory processes are we going to be using?
Neural.
Neural, absolutely. This is a this phase is neurally regulated. Right, so this is a neuroregulation of the phase. And the other thing we need to think about is it excitatory or inhibitory?
Excitatory.
Right, exactly. Because when someone comes walking towards you with that big, huge, beautiful plate of tri-tip, and you can smell the burnt flesh and you can see the blood dripping out of it, right? Ashley, that just makes you salivate in anticipation, right?
Can't it be inhibitory too?
There you go. Exactly. Right. So for many of you, that would excite the system. Ashley, who's a vegetarian, or others like that, it would be the opposite. It would be inhibitory. Right. So this one, neurally regulated, is going to be either excitatory or inhibitory. And which it is going to be has a lot to do with that top-down processing we talked about. Top-down means from cognitive thought down to basic input, right? Because again, there's a lot that goes into that steak, right? Whether you are vegetarian or not vegetarian, right? With that roasted mushroom, right? Some people love mushrooms, some people do not, right? Some people got really drunk doing mushroom poppers, or, ate mushrooms as a side dish along with some, a bunch of, Jägermeister, and so can't stand the smell or the taste of mushrooms anymore. There's all these different types of things. Heck, you could love meat and be enjoying it, and like we talked about last time, your neighbor trips and drops the tri-tip on some dog poop. Even though you still are smelling that food, is it going to stimulate your digestive system getting ready to eat at that point?
No.
No. So in this case, it can be excitatory or inhibitory. And a lot of that is driven by those internal drives, that top-down processing. Now, ultimately, our goal is to eat things we want to eat. So obviously, we want this process to primarily be excitatory. And so the goal of that excitation is going to do things like increase the production of gastric juice, and get an increase in motility. Now, again, our goal is to talk in terms of what the stomach is doing. But is this cephalic phase going to influence other things as well? Yeah, absolutely. Like, again, if it's excitatory, for instance, you can get an increase in saliva production. Right, or something along those lines. Right, so again, there are going to be other factors that are going to be influenced by this as well.
Can I ask you?
Yep.
What about chewing? When you're chewing bubble gum, it makes stomach works, no?
Yes, absolutely. The taste of the sweetness in some instances, the act of the chewing can be one of those things that stimulates activation of the stomach. Absolutely. All right, and let's take this one more step further. If this was excitatory, if you're being presented with food or thinking about food that you like, what is the neural pathway to the stomach? How does that excitatory signal get to the stomach to tell it what to do? Let's start easy. What branch of the nervous system is involved in that?
Sympathetic.
Well, excitatory is sympathetic. Parasympathetic.
Parasympathetic.
It's parasympathetic. And again, as someone mentioned out, that would be the vagus nerve that would be involved in that. If instead it was inhibitory, what branch of the autonomic nervous system would that be? Sympathetic, excellent. And what would the pathway there be? What nerves go to the, what sympathetic nerves go to the stomach? Well, okay, I'll see if we can start easy. What ganglion innervates the stomach? Those of you who had me for 430, I'm pretty sure I told you that autonomic stuff is the most important stuff you would need moving forward. Well, okay, I will remind you it is a collateral ganglia. So let's baby bird this, right? How many collateral ganglia do you have in your sympathetic nervous system? You know, a little part of me dies on the inside every time I get all these blank stares back at me. All right, there are 3 collateral ganglia: the celiac, the superior mesenteric, and the inferior mesenteric. Which of those 3 ganglia innervate the stomach?
Celiac.
Thank you, celiac. So it is the celiac ganglion. I will point out this is the second time we've talked about pathways in the digestive system. We talked about pathways in the cardiovascular system. If this autonomic stuff isn't familiar to you or you've forgotten it, might want to go back and look at that chapter again to make sure you understand these pathways. And that celiac ganglia actually produces sympathetic nerves that innervate the stomach. So that makes it easy. The sympathetic pathway is sympathetic nerves. The parasympathetic pathway is vagus nerves. And that sympathetic pathway comes to the stomach, goes out of the celiac collateral ganglia. But the point is, the goal is to stimulate the stomach, prime the pump, get it ready. But again, if you're that vegan at a keto dinner, right, that's not necessarily going to be a very fun experience for you. Right? If you are that little kid being forced to eat broccoli when you hate broccoli, right? The stomach's not going to get primed as a result of that. So our goal is to get it primed, but even if you're that little kid getting the broccoli shoved into your face, eventually you're going to have to swallow it and it's going to reach the stomach. And when it reaches the stomach, that gets us to our second phase. And our second phase is going to be that gastric phase. Oops, what just happened? Sorry. All right, do you see my whiteboard now?
Yes.
Okay, excellent. As the name gastric phase would tend to indicate, this is going to occur when the food reaches the stomach. All right, so this is when food reaches the stomach. Now, and I'm going to do it a little bit out of order here. Let's think about this. If you're that little kid and you like broccoli, or you're that little kid and you don't like broccoli. Either way, that broccoli gets shoved into your mouth, you're forced to swallow it down into your stomach. And once it's in your stomach, does your stomach really care whether you like or do not like broccoli?
Not really.
No. So this phase is primarily excitatory. All right? Because our goal here is to deal with the food that is inside of it. We need to deal with the food inside the stomach. Now, for our gastric phase, this is going to be both neural and it is going to be hormonal. the neural, this is primarily going to be that enteric plexus we talked about. Right? We talked about that gut brain, how we make local decisions. We have a local stimulus. That local stimulus is a pH change or a stretch of the stomach or the presence of a particular amino acid or something along those lines. That information gets processed locally. And the result of that local processing is we get an increase in gastric juice formation. We get an increase in our motility. And we stimulate the enteroendocrine glands. And of course, those are the G glands, or G cells. I should say enteroendocrine cells. Those G cells, and remind me again what they produce. Gastrin. Excellent. And that gastrin is going to be the hormonal control. Gastrin, as we talked about, has several effects, but the effect on the stomach is excitatory. And that excitatory effect on the stomach, again, is going to cause an increase in production of gastric juice, an increase in motility, because again, our goal here is to process the food inside of it. Sure. But I will warn you, there are other enteroendocrine cells that we are going to run into that don't have cute names like G cells. So you're not going to get out of having to spell enteroendocrine. But I wouldn't have a problem with using G cells in this case. Now, notice I keep saying mostly excitatory, mostly this, mostly that. If I have to tie that kid to the chair and beat them with a hammer to get them to open their mouth, and then I have to clamp their nose and put my hand over their mouth to get them to swallow that broccoli. Even when the broccoli hits the stomach, is their stomach going to be excited about working on that food?
Maybe not.
Probably not. So with things like extreme stress, things like depression, right? Neural things, can it be inhibitory? And also internally, if the pH is too low, if it is too full, right? Those types of both local and emotional stresses can cause this to be inhibitory. And in the most extreme case, that can cause a reverse peristalsis. And what do we call that reverse peristalsis?
Vomiting.
Throwing up.
Regurgitation, exactly, that regurgitation. So in extreme cases, it could actually cause a reverse peristalsis that would cause regurgitation. So is it possible for this stage to be inhibitory? Yes. But is it normally? No. Because again, the goal is to process the food that's inside of it. But if there's some type of emotional or physical stress, right? If you're in a lot of pain, right? Like I said, if the pH is too low, the stomach's too filled, you're depressed, you're too stressed, it can be inhibitory. But not the same way that the cephalic phase is. All right? Questions on that? All right. Now, go ahead.
I'm sorry. How you spell this reverse process?
I'm sorry?
How you spell this reverse process?
Regurgitation? You can say vomiting.
Oh,
That'd be fine. Throwing up, yakking. There you go. Or you can spell it that way.
thank you.
All righty. Now, part of that processing is the expressing of that now chyme into our small intestine. So actually, we should probably do that. As it's processing, right, it is going to express, well, let's say it this way, form the chyme and express it to the small intestine. As it forms the chyme and expresses it in the small intestine, that leads us to, not surprisingly, the intestinal phase. And of course, the intestinal phase is going to be when the food reaches the small intestine. Now, remember, our cephalic phase could be excitatory or inhibitory. Our intestinal phase is excitatory and inhibitory, right? Cephalic can be one or another. You either like mushrooms or you don't. You either like tri-tip or you don't, right? So it's not one or the other, but here it's one and then the other. First, it is excitatory. When the chyme is presented to the small intestine, it causes the small intestine to stretch. And when the small intestine stretches, its enteroendocrine cells, and these are not called G cells, but these intestinal enteroendocrine cells release intestinal gastrin. Now, we're calling it intestinal gastrin to remind us where it's coming from, but it's gastrin. And does the smooth muscle of the stomach, does the parietal cell, does the chief cell care where that gastrin comes from?
No.
No. So when our small intestine releases gastrin, that stimulates the stomach activity, just like the gastrin from the G cells does. We get more motility, we get more production of gastric juice. But this excitation is short-lived. And then it becomes inhibitory. And not surprisingly, this inhibition is going to be both neural and hormonal.
How short the excitation?
I'm sorry?
How short the excitation? You said it short-lived.
I don't think, it's not like it's, again, it's not like 5 minutes and then it stops. It's just in the grand scheme of the 2 to 4 hours that it takes the stomach to empty, there's a brief period of time where it's excitatory, but then it becomes inhibitory. So we don't have to worry about putting a number. It's not like it's 5 minutes and then it shuts off.
Okay.
It's producing that gastrin, but then we have these other inhibitory influences. The first one is neural. With this neural, hold on. There you go. All right. Neurally, what happens is we call the gastrin or gastric reflex. Basically, what happens is 3 things, right? The first thing it is going to do is it is going to inhibit the vagus nerve. excuse me.
Bless you.
Vagus nerve, as we know, is stimulating the stomach activity. So if we inhibit it, that's less excitation to the stomach. It is going to stimulate the sympathetic nerve. Sympathetic nerve inhibits the activity of the stomach, and it inhibits the local receptors as well, the short reflex as well. So that enteroendocrine, the enteric plexus, it inhibits, and actually let's put it that way, let's just write it that way. It inhibits the enteric plexus. So notice the positive stimuli, it is decreasing, and it is increasing the negative stimuli to the stomach, and that is going to slow the stomach down. Slow the motility, slow the juices that are producing. Why do we want to slow the stomach down? Don't we want to empty the stomach as quickly as possible?
No.
So you
Why
could
not?
absorb all the nutrients.
Right. Remember, the stomach isn't the important organ. The important organ is the small intestine. The small intestine is the workhorse of the digestive system. It is where the majority of the work in the digestive system takes place, is in the small intestine. Okay? And so because of that, we want to make sure that the small intestine has time to process the food properly. In my mind, I always envisioned that old I Love Lucy show where there was the one where she was at the candy making plant, where she had to take the candies and and put them onto the trays. And at first she's doing it fine, and then the faster the candies come down, right, the harder the time she has processing them. And it's the same thing with the small intestine. We only want a little bit of food presented to the small intestine at a time, so it is able to do its magic, completely break it down, and be as efficient as possible at absorbing it. So we don't want the stomach rushing the food into the small intestine. We want the small intestine to have time to process it. So having these types of inhibitory inputs are going to do that. And we're not just going to rely on neural inhibition as well. There are lots of hormones. And again, we're not going to talk about all of them, but there are many hormones, cholecystokinin, gastric inhibitory peptidase, with anything called gastrin inhibitory peptidase. Guess what? It inhibits the stomach. So there are going to be, and we'll talk about the hormones when we talk about the small intestine. There are going to be many hormones that are going to also inhibit the activity of the stomach. With, again, our goal here to be to slow the processing of the food so our small intestine has more time to process it completely. I've filled the page with words, but let's look at the pretty picture from your textbook to see this. Again, here we have that cephalic phase. Remember, the cephalic phase can be excitatory or it can be inhibitory. It's the cephalic phase because it is before the food enters the stomach. It can be in the alimentary canal. It could be in the mouth. You could be tasting it. But it can also be outside of the alimentary canal. It can be the seeing, the smelling, the thought of the food that sends that signal through the vagus nerve to the stomach and increases the secretions and increases the motility. Now, again, that is what we want to have happen. That is the goal, because we want this to be excitatory. However, as we mentioned, it can be inhibitory if the food you're seeing, smelling, tasting doesn't taste good, looks bad, right? It's sitting in dog poop, right? It has maggots crawling on top of it. There are lots of ways that when we see this, right, it's not going to prime the pump and get it ready because we're not going to be excited about eating it. All right. Once the food hits the stomach, then the goal pretty much is to process what's there. Can some external stressors cause this to be inhibitory? Yes. But for the most part, what we have are local cues giving us that stretch, that pH, that substrate, controlled by or regulated by our enteric plexus. Right, our submucosal plexus, remember, is the branch of the enteric plexus that increases glandular activity, and the myenteric plexus is the one that increases the motility. So more muscle contractions, more churning, more gastric juice being produced, and we produce and release that gastrin. So it is hormonal as well. And that gastrin does many things, but on the stomach, it stimulates contractions of the stomach. It stimulates production of gastric juice. So gastric phase is excitatory with both neural and hormonal control. And again, remember, this gastrin that is being produced is not released into the lumen, right? It's a hormone. It's released into the interstitial fluid, gets into the blood. So notice even here, they remind you, it gets into the blood, it gets into the circulation, and then goes to the chief cells, goes to the parietal cells, goes to the muscularis externum. However, its job is to start expressing that chyme into the small intestine, where we hit the intestinal phase. Intestinal phase is both excitatory and inhibitory. Excitatory first, and then inhibitory. First, it's excitatory in that it stimulates the release of gastrin. And that intestinal gastrin works the exact same way as normal gastrin does, stimulating the stomach to produce more contractions, to produce more gastric juice. But that is only a brief effect. Then it becomes inhibitory. Neurally, like we see here with that enterogastric reflex, and as we can see, that enterogastric reflex inhibits the vagus nerve so that slows down the excitation of the stomach, inhibits the local reflexes, the enteric plexus, decreasing stomach activity, and it stimulates the sympathetic pathway, which suppresses the activity of the stomach. So we get this neural decrease in activity of the stomach. But as we also said, it is going to produce hormones like cholecystokinin, like secretin, like gastrin inhibiting peptidase. And these hormones, which we'll talk about when we talk about the small intestine, these hormones are going to suppress the activity of the stomach, slowing the activity so that our small intestine has more time to process it.
So would you say it's mostly inhibitory?
Yes, I would say it is mostly inhibitory, but it definitely is both. I mean, there definitely is an excitatory. It's not like, the gastric phase, which is all excitatory, but sometimes in rare instances can be inhibitory, right? It's not like that. This is both. It is definitely excitatory first, but then it's inhibitory. So it's not a fast process. It's a long process, obviously, with a little bit of excitatory and then a whole lot of inhibitory.
And then for the cephalic phase, one of the inhibitory things is it inhibits the parasympathetic nerve system.
Well, so great question. Excellent question. So when we have things like depression, loss of appetite, not liking the food, typically those are things that are uncomfortable. Those are things that are stressors. So typically what they actually do is they increase sympathetic input. So here what we get is more of an increase in the sympathetic output. And that increase in the sympathetic output suppresses the activity of the stomach. So again, when we first looked at this chart, it was a little confusing when you first looked at it, but actually it does really do a nice job of showing all of the different phases and all the different components of it. So yeah, with the excitatory stuff over here, we're pretty much getting an increase in parasympathetic. And that is increasing the activity of the heart, the stomach, getting it primed, getting it ready. Whereas the stress, the being vegetarian and someone serving you meat, right, seeing the maggots on it, all those things typically increase the sympathetic, which inhibits it. And like we said, that stress, that emotional upset, or local cues like a really acidic stomach can actually override these controls and can increase the activation. And again, if it becomes uncomfortable enough, can actually trigger a reverse peristalsis. But what ideally we want to have happen is we want the gastric phase to be excitatory because we want to process that food. And then, yeah, intestinal phase is mostly inhibitory. We don't want it to be so inhibitory that the stomach stops expressing food. Really, it's not so much that we want it to be inhibitory, it's that we want to control the rate. We don't want it to go too fast. We don't want to stop it. We just want to control the rate so that it doesn't go too fast. And that's really what this intestinal phase is about. It's about controlling the rate so that it doesn't go too fast. Excellent. Questions on that? Perfect. As I mentioned, our goal is to empty the stomach. We are going to do that by producing those peristaltic waves. So we talked about those peristaltic waves move through the stomach. They become more powerful when they reach the pyloric region. That pyloric region only contains about 30 milliliters of chyme. And as those powerful contractions come down, they express the smallest amount, only about 3 milliliters of chyme is presented to the small intestine from one of these peristaltic waves, and the rest bounces back and mixes in with the rest of the food. So those peristaltic waves, just 3 milliliters at a time, pinch off a small amount of chyme and present it to the small intestine so that it can be processed by the true workhorse of our digestive system, the small intestine. All right, questions on that? All right, that is everything we wanted to know and more about the stomach. So any questions on the stomach, anatomy, physiology, control, before we move on to the small intestine? All right, excellent. Stunned silences, of course, always mean we have mastered the material. Dr. Slutsky, please make the tests harder. Love it. All right, excellent. So on to our small intestine. I always giggle every time I say small intestine, girlishly. And the reason for that is, as we mentioned, our alimentary canal is a hollow tube that in that cadaver is 30 feet long. 20 of those 30 feet are your small intestine. How the heck is anything that is 20 feet long called the small intestine?
Is it about diameter?
Exactly. It's all about diameter, right? It is small in diameter, and so that is why it is called the small intestine, because it is small in diameter. Like the esophagus, like the stomach, it is bounded by sphincters on both sides. Obviously, the first one, as we've already talked about, is that pyloric sphincter between the stomach and the small intestine. But at the distal end, where it meets the large intestine, there is another valve called the ileocecal valve. All right. Why is it called the ileocecal valve? Come on, these are the easy questions, folks. Right, because the distal part of the small intestine is the ileum, and the proximal part of the large intestine is the cecum. So it is the valve between the ileum and the cecum, so it's the ileocecal valve. All right. No, there was not somebody named Bob Ileocecal that came up with it. Nope, it's because it's between the ileum and the cecum. Excellent. Now, the small intestine, as we talked about in the last class, is divided up into 3 distinct regions. Right? The duodenum or duodenum, you can pronounce it either way, it's fine. The ileum, obviously. And what's the third one? Jejunum. Excellent. So we have duodenum, proximal end. Duodenum is the proximal end. Jejunum is the intermediate part, and the ileum is the distal part. But it's not evenly split. Only about 5% of the small intestine is the duodenum. In fact, duodenum actually means 10 fingers because that's about how long it is. It's about 10 fingers long. That's where it actually gets its name. It, as I mentioned, is the part that, and we'll do it with the highlighter here, connects to the stomach. It wraps around the head of that pancreas. That's that feather-like yellow structure that is seen there. And remember, the duodenum is the part that is retroperitoneal. Whereas the jejunum and the ileum are intraperitoneal. They're located inside the abdominal pelvic cavity. And the majority of it is the ileum. The jejunum is about 40%, and the ileum makes up almost 60%. So the largest portion is the ileum. The smallest is the duodenum. Now, like I said, the small intestine is the workhorse of the digestive system, doing much of the work. However, is that work equally distributed throughout all parts of the small intestine? No, the majority of the work is done at the proximal end. So the majority of the work is done at the proximal end, and then the remaining part of it just kind of fine-tunes things from there. So it is much more active at the proximal end and less is done at the distal end. Now, the other thing that I want to emphasize is that this is a big tangle of intestine, right? Sometimes some of the illustrations you'll see that they will like color this part up here as the jejunum and this part down here as the ileum. And is it always going to be perfectly divided like that inside of your abdominal pelvic cavity? No. Again, is it more likely that the jejunum is more superior and the ileum is more inferior? Sure. But there's nothing stopping this from all interweaving with itself. Well, I guess the mesentery stops it from completely tying up in a knot, but it's not going to be perfectly defined into distinct regions that way. That doesn't mean that we can't tell which part is which. However, we're not going to be able to do that by just looking at it from the gross anatomy. Luckily, we will be able to distinguish it histologically. So we will identify them under the microscope. Like I said, the stomach may get the rock star status even if it doesn't deserve it, but the small intestine is the workhorse. We have seen how carbohydrate breakdown started in the oral cavity. Protein and lipid chemical breakdown started in the stomach. But we haven't talked about nucleic acids yet. And starting isn't finishing. The breakdown, the completion of the breakdown of our proteins, carbohydrates, and lipids is going to finish in the small intestine. And all of the breakdown of our nucleic acids are going to occur in our small intestine. The small intestine is the primary organ where absorption takes place. About 90% of all of the substances and all of the water is absorbed in the small intestine. I know some people incorrectly like to think or point out that the large intestine is the primary organ where water absorption takes place, and that is not accurate. More water is absorbed in the small intestine than the large intestine. The reason sometimes people mistakenly say that is because one of the primary functions of the large intestine is the absorption of water. It doesn't do a lot of absorption, but most of what it absorbs is water. And so its primary job is absorbing water, but it's not the main location where it occurs. As we talked about in the cardiovascular system, we also know that the blood vessel pathway is very special. We know the blood vessels that feed into the digestive system, like the small intestine. And what's the primary organ, the primary blood vessel that feeds into the small intestines?
Is it inferior mesenteric?
It is one of the mesenterics, but is it the inferior one that goes to the small intestine?
Superior.
Superior mesenteric, absolutely. The superior mesenteric is the primary way we get blood to the small intestine, right? And then on the way back to the heart, where does it go? Hepatic portal vein, and that hepatic portal vein takes it where?
Liver.
To the liver, absolutely. So we're finally going to get to talk about that magic box that is the liver and some of the things that go on in there. As I mentioned, it is most active in the proximal part, and all three parts are very highly specialized and easy to distinguish histologically. So that is absolutely positively something we are going to look at. Before we look at the histology, though, let's look at some illustrations that show the three main specializations to the small intestine. Notice starting here, we have structures that look a little bit like the rugae that we talked about in our stomach. Notice we have these big folds, and these big folds involve include both the mucosa and submucosa. These we called rugae in the stomach, but in this case, there are these big raised ridges that basically form these large circles inside of the small intestine. So they are called the plicae circularis, or what are also sometimes referred to as the circular folds. Plicae circularis is way more fun to say, but you're not required to say it. So if you want to use circular fold, that is fine as well. And again, I want to emphasize that this is comprised of both the mucosa and the submucosa. All right. Notice here, as we see here, there are also extensions off of those circular folds. So off of the circular folds, again, comprised of both let me rephrase that. These circular folds coming off here involve the mucosa only. And these structures that come off the mucosa only are our villi. These villi, as we saw and talked about in the last section, have long, blunt-shaped lymphatic capillaries that extend out into those villi. What were those big, blunt-shaped capillaries called again? Lacteals, excellent. We have those lacteals that go off in here. And then we also have some blood vessel capillaries that come up into here as well for the absorption of our nutrients. And if we look along the surface of these villi, and I'm not going to be able to draw these to scale, but along the surface, we have our simple columnar cells that are lining the surfaces of these. They are, of course, simple columnar cells. Oops. And these simple columnar cells have long hair-like extensions that stick off of the surface of them. And what would these long hair-like extensions that would help to increase our surface area be called?
Microvilli.
Microvilli.
Or brush border, right?
True, or yes, this is also referred to as the brush border. because it's got all those bristles like a brush. So these microvilli along the surface as well. So notice there are these three specializations: circular folds, villi, and microvilli. And collectively, they increase the surface area almost 1,000 times what the surface area would be of it if it was just a straight hollow tube. This gives us a massive surface area on the inside of our small intestine, because again, this is the primary location where absorption is going to take place. I think we have it here too. If we go back here and go back there, if we look at the digestive models, do they not have it? Weird. Okay. Well, it was on the last test, I think. I wonder if it's going to be under histology. Should probably look at these things ahead of time before we do this. But that would require preparation. All right, I'll get it for you next time. But it was on your last exam. There's a good, cool model of the plaque of the digestive, of the small intestine in your, and we used it to look at a lacteal on the last test, as well as a Peyer's patch in there too. All right, so never mind. We'll worry about that for the next class. There you go. All right, so increase the surface area. This increase in surface area does a couple things. Again, it's going to basically form speed bumps that is going to slow the chyme so that it doesn't pass through the small intestine too quickly. Because surprisingly, even though it's 20 feet long, we still want to regulate the control of how quickly it gets through there so we can do all the processing. Again, those villi are non-motile. Oh, here's a great picture. Again, we see that lacteal located within the villi. And then here we have the microvilli, which are also non-motile on the surface of that as well. The epithelial cells in your small intestine do not have the protections that your stomach does, because in this case, we want the food to come in contact with our small intestine wall so that we can absorb the nutrients. So not surprisingly, these cells are damaged rapidly. In fact, an epithelial cell in your small intestine only lasts about 3 days. So they only last for about 3 days, and they're constantly being replaced. Very, very rapid. This is one of the things that also individuals dealing with chemotherapy, right? Chemotherapy is where basically you put toxins in the person's body that are targeting rapidly dividing cells, because that's what cancer cells do. But guess what also does that? The lining of your small intestine. So often people, when they do chemotherapy, have a large amount of intestinal problems that come along with it, right? They lose their hair because the matrix of the hair is something that divides rapidly. So those are common things you see with chemo because of those targets. Small intestine being sterile. Well, we have the acids of the stomach protecting the chyme that comes in. And we have things like the Peyer's patches and stuff like that protecting helping to decrease the amount of bacteria that can get from the large intestine to the small intestine. So let's put it this way. It's definitely not full of bacteria, but I wouldn't want to eat off of it. So I'm not sure, again, not my area of expertise. I'm not so sure I would go so far as to say it's sterile, but definitely do we want to limit how many bacteria is in there? Yeah, absolutely. And so we do have things like the acidity of the stomach. We do have things like the Peyer's patches, the ileocecal valve to help to limit the bacteria that can get in there. But I would have a hard time believing there's no bacteria in there, just because there's bacteria so ubiquitous everywhere. All right. All right, well, there you go. Well, look, it's the same way with our urine. When you first produce urine, urine is sterile, but it also has to pass through the urethra to get out, which is one of the reasons why, for instance, if you're doing a urine sample, you don't want to take the first bit of urine that comes out. You want to let the urine flush the urethra first before you take your sample of that. And again, just because it's sterile doesn't mean you should drink it. Same thing here. So again, I think that it makes sense that we would definitely want to limit the number of bacteria that were in that location. So, and then there you go. Completely new epithelium about every 3 days. And here we have a pretty picture. And again, they've simplified it by showing the entire jejunum superiorly, the entire ileum inferiorly. But again, it's not going to be that. However, what I do like about this illustration is it does a really nice job of showing that short duodenum that is going to wrap around the head of the pancreas. Excellent. More pretty pictures, again, showing, and again, I like this picture a lot because this one again shows how the circular folds, the plicae circularis, are comprised of both mucosa and submucosa, whereas the villi are just made of the mucosa. And then obviously at this magnification, we're not seeing the microvilli. Again, lacteals within those villi, we see those really nicely, as well as small capillaries. Notice the occasional lymphatic nodule that we find in here. And again, here is that muscularis mucosa. So again, remember everything from here up is mucosa, and then our submucosa. We are now back to the small intestine, so just 2 layers of smooth muscle, circular and longitudinal, and then that serosa. Unless it's the duodenum, in which case it would be an adventitia. And again, a close-up view of the plicae circularis. Again, those plicae circularis are made of both submucosa and mucosa, whereas the villi are just mucosa. All right, so this is the general anatomy of all of the small intestine. However, as I mentioned, histologically, we need to be able to distinguish the 3 layers. What we want to do is make this as easy as possible. So what we are going to do, as soon as we figure out we are looking at the small intestine, we are going to look in the submucosa. Because what's going on in the submucosa is going to tell us what portion of the small intestine we are looking at. Remember when we looked at that pyloric sphincter, one of the things we noticed, and as I mentioned, is in the submucosa, there were these major massive glands. These glands happen to be called Brunner's glands. And of course, why are they called Brunner's glands?
It anatomically makes sense.
Exactly. Yep, because Bob Brunner is the one who identified them. Absolutely. However, the other name for these Brunner's glands is that they are the duodenal glands or the duodenal glands. And guess what part of the small intestine you find duodenal glands? In the duodenum, absolutely. So in the duodenum. So if in the submucosa you see these massive mucus producing glands, you know that you are located in the duodenum. These Brunner's glands produce mucus and they produce bicarbonate. Notice there are intestinal glands we can see at the base of the villi. They are also producing mucus and bicarbonate. But here in the duodenum, we want even more mucus and even more bicarbonate. Why do we want all this mucus and bicarbonate here in the duodenum? Right, because the duodenum is what receives the chyme. And chyme's at a pH of about 2 to 1. So we need to neutralize that acidity of the chyme. We need to protect our lining of our small intestine here and make that chyme more palatable, excuse the pun, for the small intestine to do its work with it. So having these big, massive glands in here are something that's going to be helpful. Notice it has villi, like we expect to see. They're not super extensive, but they're good sized villi. And like I said, prominent intestinal glands. But the most prominent thing is that these Brunner's glands. And notice also, clearly this is not the stomach anymore because we have a circular layer and a muscular layer, only 2 layers to the muscularis. And then, of course, this outer layer, what must this outer layer be?
Longitudinal.
No, what's the outer layer? Adventitia, right? It's not a serosa because remember the duodenum is retroperitoneal, so it would be an adventitia. Here's something that should look familiar from your last test. Once again, we look in the submucosa, and when we look in the submucosa, we see this massive cluster of dark stained things. What the heck are these massive cluster of dark stained things called? Byers patches. Excellent. They're lymphatic follicles. Each one of these is a lymphatic follicle with a germinal center located in the small intestine. These Byers patches in the submucosa is a dead giveaway. We are looking at the ileum. Notice it also has villi. These villi are not quite as extensive as the ones we saw, but relative size of the villi, especially when you don't have them side by side to compare, can be a little tricky. So the easiest thing to do is look in the submucosa. Look in the submucosa. What do you see here? Do you see massive mucus and bicarbonate producing glands? Do you see massive Byers patches, lymphatic follicles? So if you see neither glands nor Byers patches, what region of the small intestine must you be in? Jejunum. There you go. You're in the jejunum. Notice the jejunum tends to have the most extensive. Remember, we do more processing at the proximal part. But again, just because it has massive villi, that can still be tricky to tell. It's subjective. It can still be somewhat subjective. But that's why the submucosa is the easiest thing to do. Look in the submucosa, and that will instantly tell you where you are. You either have duodenal glands in the duodenum, Byers patches in the ileum, or neither, in which case you're in the jejunum. And it really is just that simple.
Byers patches all around the ileum?
So, no, great question. Notice it doesn't go all the way around. However, if I'm going to show you a picture of the ileum, am I going to pick the part up here that doesn't have Byers patches, or am I going to pick the part that does have Byers patches?
Hope second.
Yeah, and if I'm asking you to distinguish these things, I'm going to give you the obvious examples. I'm not going to show, is it possible to take a section of the ileum that doesn't have Byers patches in it? Yes, absolutely. Am I going to show you that on the exam? No, absolutely not. Any example I give you of the ileum will have Byers patches in it. Okay? I'm mean, but I'm not a jerk. All right, questions on that? All right, excellent. Let's talk about the work of the small intestine. Again, The work of the small intestine obviously starts when chyme enters into the duodenum from the stomach. And it is going to do its own secretions. It produces, for instance, an intestinal juice. Again, depends on how many times you eat, the volume of the food you eat, the composition of the food you eat. But on average, your small intestine produces about 2 liters of intestinal juice during the course of a day. That intestinal juice is primarily water and bicarbonate ions, right? Those bicarbonate ions, remember, as we talked about, are going to neutralize the acidity, right? We're going to produce mucin. Not a massive amount of it, but enough to grease the wheels and enough to provide some protection. And obviously, we're going to produce hormones to control the rate of digestion, both in the small intestine, in the stomach, and in the accessory organs as well. And not surprisingly, this is regulated both by our neural stimulation. The small intestine can be stimulated as early as the cephalic phase, right? Again, we were focusing on the stomach, but it can also, seeing, smelling, thinking about food, can affect the small intestine as well. So again, central nervous system control, local reflexes, and hormonal control. So not surprisingly, all 3 are going to play a role in regulating our small intestine's activity. Now, one of the big differences between what happens in the small intestine and what happens in the stomach is how we control it. The stomach, as we said, once the food got in there, we had that gastric phase and it was excitatory, and it didn't matter whether it was a bucket of broccoli, right, or a bucket of chicken. It affected it the same way. The same is not true for the small intestine. The composition of the chyme has a big impact on how we control the stomach and everything else. Because how easy it is to break down carbohydrates is different from how easy it is to break down proteins or how easy it is to break down fats. So the composition of the chyme is going to have a big impact on the control of our digestive system. Let's talk about some simple examples. As we mentioned, the small intestine will be stretched by the presence of chyme, and that stretch by the presence of chyme will stimulate goblet cells to produce mucus, those Brunner glands to produce mucus, because again, we need to grease the wheels. Remember, we also talked about how those stretch receptors are going to stimulate gastrin production. I don't know why that's so tiny. Also, the presence of certain certain amino acids will stimulate the production of gastrin as well. Now, we talked about gastrin's effect on the stomach, but gastrin, being a circulating hormone, is going to affect other things as well. Gastrin doesn't only increase the motility of the stomach, it also increases the motility of the small intestine. Gastrin also relaxes the ileocecal valve, right? After all, when food is first presented to the proximal part of the small intestine, or even the gastrin released from the stomach, tells the small intestine, hey, more food is on the way. You've got processing to do. And if we have new food to process, we have to get rid of the old food we're processing. So we want to move that food out of the small intestine into the cecum, into the large intestine, so that we can start processing new food. Again, you may not have thought of it in these terms, but many of you who have kids are aware of it. because a kid's digestive system is much, much smaller than ours as an adult. So what happens is that 4-year-old comes down, sits at the table, takes 3 bites of food. As they take those 3 bites of food, it goes down into their stomach stretches, their stomach produces gastrin. That gastrin goes to the ileocecal valve, relaxing it, so that a bunch of chyme is put into the large intestine. And so after those 3 bites of food, what does that little kid need to do? Come on, I know my kids aren't the only one. There they go. They got to run to the bathroom. They got to poop. Absolutely. Right? Because it's moving things on. So as soon as they take a couple bites of food, they got to go run to the bathroom because we're moving the food along so that new food can come in. Absolutely. But other presence of other compositions of the chyme will have different effects. Lipids in particular. Lipids are the most challenging thing to break down. So not surprisingly, when we produce lipids, it takes a lot more work. And so we really want to slow the system down. There are some amino acids that will trigger a similar effect. But primarily when we talk about cholecystokinin, cholecystokinin's goal is to help us to deal with lipids. And the reason we know this is what cholecystokinin does. Cholecystokinin stimulates our pancreas to produce more digestive enzymes. Most of the enzymes that are used to break down our food in the small intestine come from the pancreas. But it also stimulates our liver, and it stimulates our liver to produce and release bile. What does bile do?
Helps to break down the lipids. Fats.
Absolutely. But again, remember, breakdown is a tricky word. We know breakdown could be chemically by breaking bonds or mechanically by spreading it out. Which one does bile do? Does bile chemically or mechanically break down lipids?
Chemically breaks down bonds.
It's awesome, right? We've all experienced this. You have that lasagna for dinner. You take that lasagna dish, you put it in the sink, you fill it filled with water. And if you made that lasagna correctly, you're going to have this big, huge, massive pool of oil sitting on top of that water inside of that lasagna dish. And then what you do is you take the dish soap and you put just a single drop of that dish soap into that bubble, a big, huge pool of fat, and it completely disappears. And the reason it disappears is because we have emulsified the fats. What emulsifying a fat is, as we know, fats are hydrophobic. They don't like water. So when you put that water in the dish, because all the fats don't like water, they all pool together in the center. But when we add that dish soap, it emulsifies the fats. And what it does is it takes that single big glob of fat and breaks it down into a bunch of tiny little pieces of fat. Kind of like taking a chisel and breaking a boulder down into a bunch of tiny little pebbles. And if we take that hammer and chisel and break a boulder down into a bunch of tiny little pebbles, are we breaking it down chemically or mechanically? Mechanically. Bile mechanically breaks down the fats. Emulsification is a mechanical breakdown. Well, the key with a keto diet, trying to convert the body into burning fat isn't so much because of the bile or the pancreatic enzymes or even cholecystokinin for that matter. It is that you are restricting the carbohydrate input into the body so much that it is basically starved of carbohydrates and has no choice but to convert to fat burning. So that's really the goal of a keto diet, is to limit the carbohydrate input so much that the body is basically forced to switch to fat burning as opposed to carbohydrate burning, because those carbohydrates aren't as readily available. Now, the liver makes the bile, but it doesn't constantly release it into your small intestine. It is constantly making it though. So if it's constantly making that bile to emulsify the fat, but it's not constantly leaking into the small intestine, what do we do with that bile? We store it in the gallbladder. And not only do we store it, but we concentrate it. When that bile enters into the gallbladder draws water out of it. It can actually concentrate it up to 10 times as concentrated as it was when it was first made. So it makes that bile really, really potent, right? And so not only does cholecystokinin stimulate the liver to produce and release bile, but it also stimulates the gallbladder to release bile as well. And for the gallbladder and the liver, and we'll look at this anatomy later, to release those contents into our small intestine, it also has to open and relax a hepatopancreatic sphincter. Now, the hepatopancreatic sphincter is a big mouthful, but again, it tells you what it is. Hepato, of course, refers to the liver. Pancreatic refers to the pancreas. So this is a valve for ducts associated with both the liver and the pancreas. So in this way, it is going to release these contents into our small intestine. And I don't think it says it here, so I want to make sure I emphasize it. Perfect. Don't forget that also, if we think back to what we were talking about in our gastric regulation, cholecystokinin, let's make it big, inhibits the mechanical activity of the stomach. It slows down the churning, because if we slow down the peristalsis, right, we are slowing down the rate at which chyme is presented to the small intestine. And so this way, by slowing it down, we get less food presented to the small intestine, and it is more time to process the chyme. All right. Questions on that? All right. If instead your diet is more glucose rich, or certain fatty acids are present, then our small intestines enteroendocrine cells produce gastric inhibitory peptase or peptide. This stimulates insulin to be released. Where is that insulin released from? What store? Pancreas. All right, you get partial credit for pancreas, although after the last section, we should be able to do better than that. Beta cells, excellent. Perfect, right? The beta cells of the pancreas to release the insulin, because after all, what the small intestine is saying is, hey, there's a bunch of sugar inside of me right now. That's going to be in the blood in a few minutes. Get ready. And it decreases the production of gastric juices. Again, slowing down the rate of the activity of the stomach. If the chyme entering into the small intestine is too acidic, then our small intestine's enteroendocrine cells release a hormone called secretin. Secretin's job is to slow down the motility of the stomach so less chyme is entering it. But we also want to slow down the production of hydrochloric acid. So we want to inhibit those parietal cells because we're saying, whoa, the chyme coming in is too acidic. This can be damaging to the small intestine. So let's stop giving as much chyme to the small intestine, and let's stop producing as much acid so that we can kind of bring the pH back up a little bit so we can neutralize this a little bit more easily. This also is going to stimulate our pancreas. Remember, those acini of our pancreas have a major exocrine function where they can produce enzymes, but it also can produce bicarbonate. And bicarbonate is going to help to neutralize the acidity. So this way it tells the stomach, slow your roll, stop giving me so much stuff, but hey, pancreas, I need a little help in neutralizing this acidity. So again, one of the things that I want to emphasize about the small intestine is a lot of what's going on inside of it is related to the composition of the chyme. It isn't just cheeseburger hit stomach and stomach stretch, right? Whether you're eating carbs, whether you're eating, proteins, whatever, the composition of the food matters. And our small intestine can accommodate to make it as efficient as possible for its processing. Again, this is just the tip of the iceberg. Notice there's some other interesting one. Histamine, for instance, can be produced. Again, we think of it as in our immune response. We talked about our inflammation, but it also actually can stimulate the release of hydrochloric acid, which, again, if you think about, makes sense. If there's some type of infection, if there's some type of inflammation, we may want to produce hydrochloric acid to provide more protection from any pathogens that may be trying to get in through our digestive system. And there are a bunch of other ones as well. Some we won't talk about, serotonin, somatostatins, things along those lines. We won't talk about those. But the point is that there's a lot of these, and I gave you some good examples. All right. And then here we see the nice flow chart that kind of shows how all of this happens. The goal of this is to control the rate at which the stomach empties into the small intestine, so that the small intestine can complete both the chemical and the mechanical breakdown of the food. All right. Questions on that? All right, let me see where we are. Perfect. This is a good stopping point. We could go one more slide, but I think we've done enough. I think we've gotten where I wanted to get to for today. And that will allow us to do all of that tomorrow and then all of that. Perfect. That'll work. Excellent. There should be plenty of time. All right. So with that, that is everything that I wanted to cover for today. So any questions on that? We have a teeny bit more to do in the small intestine. And then we also will talk about the accessory organs for the small intestine, primarily the liver, the gallbladder, and the pancreas that we just finished talking about. So we have to talk about those. So that's all good stuff. And then it's on to the large intestine and out. So we're over halfway through, which is good because we're halfway through our time. Questions on any of that? Stunned silences. Excellent. Well, in that case, if there is no more information, no more questions, I think we've handled the histology that I wanted to cover as well. Then we will finish early today. If you have questions, I'm always happy to answer them. I'll stick around for a minute or two if anybody has any additional questions, but otherwise this is all the material that I wanted to cover for today. We were able to get through everything I wanted to. We're right on schedule with where I want to be. So questions on any of that? All right, have a good weekend. Be safe, be smart, listen to the doctors, do not listen to the politicians, vote. All right, if you're not already registered, register. If you haven't already voted, vote. If you've already voted, vote again. Okay, don't vote again. But you can, if you voted ahead of time or through the mail, you can monitor your vote to make sure that it was counted properly. So please do that. All right, be safe, take care, and I will see you on Tuesday.